works together. This isn't just about a building. It's about access, it's about dignity. It's about ensuring that every community has what they need for healthy, full lives. Thank you.
This clinic represents a $31 million investment by Central Health Board of Managers and is part of the Central Health broader commitment to expand access to care across our entire community, but especially in the Eastern Crescent where such disparities and inequities exist.
We all came together because we understood it was best for our Travis County community, the entire community. So you are Travis County. You are the faces of the power in this area and in Travis County.
This community shows up for its health. Since our soft launch in March, more than 3,400 neighbors have already walked through these doors for medical, dental, behavioral health, pediatric. Almost 2,000 prescriptions have been written and many dispensed through our state-of-the-art drive-through pharmacy. You will find here cooking classes, youth fitness, bright community rooms ready for what you dream. Our program is an invitation to amplify the strengths that already live in Del Valle.
Thank you. Pat, hold your ears. You can ask me later to see dance video. I may have some secret video on the down low. Pat keeps telling me to let it die, but it will never die. Once you're on video, it lives forever. And now I want to introduce Yesenia Ramos, who was instrumental in pulling off the event itself.
Thank you, Ted. And again, like Ted said, we're so grateful for y'all's participation, not only in the 4 community conversations, but also at the grand opening of the Del Valle Health and Wellness Center. I know it means a lot to our teams and a lot to the communities that we serve, so thank y'all so much for that. I know Ted already mentioned the community conversation in Manor. That was a huge success. We are kicking off our FY 2026 engagement cycle, and we will be hosting a community conversation co-hosted by Judge Andy Brown on July 31st. So y'all will receive that information. If you or any of the members of the public weren't able to join the other 4 community conversations, we do have the full recordings available on our Get Involved page on the Central Health website. If you have any questions about getting there, I can always send that info to Brianna to get that over to you. We are requesting, though, in addition to our public events, community conversations, we're expanding our reach by taking this information directly to community groups, as we have been throughout the year, especially to those that we haven't connected with yet. So we're meeting people where they are, sharing the same content and gathering their input to make sure we're being inclusive and representative as possible. So this phase of community engagement will run through August 27th, and you'll get a preliminary update in your June 25th board packet. We'll share this full engagement report with you on that August 27th meeting. In the meantime, we would love your help in identifying any groups, any communities that you're specifically a part of, well connected with. We would love your help in identifying those and joining those already existing meetings. So if you could please give that information to Brianna, and we'll gladly reach out to those. So if you have a direct contact, that will be especially helpful for us as well. And we're already lining up some presentations now, so for those already existing meetings, we are consistently meeting throughout the fiscal year. Thanks again so much for your continued support and in helping us build this health system that truly reflects the voices of the community that we serve.
Thank you, Yesenia. One final note, we have a new media relations manager that started last week, and he thinks that every week is like last week, so don't tell him that it's not that way. But Alex Booth, where's Alex? There's Alex. Alex comes to us, he was the executive producer for Spectrum News Texas, and before that he was an executive producer for CBS Detroit and was a producer in Dallas. He must have started when he was 3, because that is unheard of that somebody starts in the Dallas market as a producer, but And on a personal note, his mother is probably one of the most well-respected Latina journalists in the country. And so he comes from a long line of really prestigious journalists in his family. So we're happy to have Alex here. The reason I'm introducing him, we have lots of new employees throughout the organization, but he's somebody who might be bugging you. So when Alex calls or texts or comes and, I won't call it harassment, nudges you, you'll know who he is. So welcome Alex to the team. Thank you very much.
Team, can we give a round of applause for the communications team? Last week was a banner week.
Okay, we will now proceed to the committee agenda. Number 1, review and approve the minutes of the April 9th and May 14th Strategic Planning Committee meeting. Cynthia? Thank you. And a second?
Second.
Thank you. That's great. And now we will receive and discuss an update. Oh, vote, I'm sorry. Okay, vote, everybody?
Yes.
Okay, 1, 2, 3. Everybody voted yes. Okay. Number 2, receive and discuss an update on the implementation of the Service Delivery Strategic Plan, which is the Healthcare Equity Plan. And presenting will be Jeff Knodel, John Morgan, Dr. Shawsha, and Monica Crowley.
Thank you, Chair Brunson and Strategic Planning Committee, Monica Crowley, Central Health. And thank you for letting us bring this presentation back to you for completion. Jeff is available if anyone has any questions, but he's continuing to work on the sidelines while we're going through this. Remember, this is a continuation of a presentation that we began during the last board meeting. That the last board meeting was truncated for weather reasons and because we lost all power in the building after the meeting started. Please go to slide number 6. Manager May, these slides are our version of the kind of cleaned up, easier to digest version of the finances. Instead of pies, we used bar graphs. And what these depict, there's a slide that is a version for fiscal year 2024, where on the left-hand side, we see the estimate of the total investments from the plan that was adopted in August of 2023. And then on the right-hand side, we see the actual investments. If you look in some of the areas such as specialty and mental health, although the percentage of the total investment for 2024 went down a little bit from what was anticipated to what we actually did, because the entire pie or the entire bucket went up from $32 million to $44 million, or well, almost $33 million to almost $45 million. We actually invested more in specialty care and mental health, even though the total percentage of the bucket went down a little bit. And if you look, just the way that you would read this is that all of the investments are color-coded on the right, and those track with the different community needs.
Monica, do you want questions now, or do you want us to wait till the end? Now?
I would think for these, you should
Yeah,
ask
just take it
questions, because
now.
there are just these two slides that are kind of an update from the last presentation, and then we're going to go ahead and skip forward to where
Right.
we left off
Okay.
last time to go
Yeah.
into the details
Okay, yes.
of the
So
implementation.
now.
Okay, quick question. Can you separate the specialty and the mental health? I mean, you don't have to do it right this minute, but I'd just like to see it separated.
And Jeff, this is where I think, and Drew.
I think the quick answer is we take a stab at it. Get back with you.
Okay, great, that would be great. Thank you very much.
And then we have another version of this that is the difference from what was anticipated in fiscal year 2025 to what the actual estimated fiscal year 2025 spend. So this isn't the spend today, this is the estimate for where we think we'll end up in about 3 months at the end of fiscal year 2025. And also, as you note, the estimate that was done at the time the plan was adopted in late 2023 was a $50 million spend for fiscal year 2025 in these operating investments. And all of these investments are ongoing operating investments, so none of these are one-time costs. These are all operating costs on both the last slide and this slide. And we went from around $50 million predicted in August of '23 to a little over $84 million anticipated for this year. And, you know, once again, and we'll also take a stab on this one, Chair Kitchen, of splitting out the specialty and mental health. And just to notice, due to a much larger entire spend in the year, we didn't spend less in specialty and mental health care than we'd estimated. We actually spent more, even though as a percentage of the total bucket, that spend went down a little bit.
I just want to say, I really appreciate the way you've presented it. It's a lot clearer. You can appreciate where the dollars are going a lot easier. So thank you for your efforts in doing that.
Well, thank you for the suggestion, because when we saw it, it pops off the
It
page
does,
to you. So
right?
thank you
Yeah.
for the suggestion.
Thank you.
Okay, and then can we go ahead to, next slide, please? And this slide is just more for your reference. If you want to see over the years, this has 24 and 25 actual and estimated side by side in each one of the community needs. And I think, you know, one of the things that really stood out to the group that was working on this is just, you know, if you look at this first specialty in mental health care, kind of just that growth over what we had anticipated to what we actually invested in during these first 2 years of the program. You know, the same thing, I think, in a lot of these areas, like post-acute care, you know, there's a steady kind of increase from what we'd anticipated to where we ended up. You know, it's a little bit more marked, but the same thing for primary care and same-day care and care coordination, eligibility, enrollment, and investments in coverage and in infrastructure. There is a larger investment in IT and analytics than we had anticipated, and that is kind of, if you remember, that isn't really system-wide a new cost. That reflects when some as part of our support for community care, there were investments that had previously been on the community care side in analytics and IT infrastructure that shifted over to the central health side during fiscal year 2025.
I'm sorry, just educational point. That's almost a quarter of our budget. Is that fairly standard for this kind of operation? It's 22% of our whole budget?
Well, and it's not, remember, this is not our entire budget. There's most of the baseline services. This is the, what we've anticipated in investing in IT and analytics. And so I think that going from being around, 20%, I think it is a larger portion than we had originally anticipated. But as you're standing up new clinical services and having to build in the new electronic health record technology and stand that up across different systems, and then also investing in the IT infrastructure in new facilities. So I think during this growth period, as we built out the Del Valle Clinic, as we built out the Hornsby Bend Clinic, as we complete the, as we built out the Capitol Plaza and Rosewood Zaragoza clinics, and then next as we move into Hornsby Bend, not Hornsby Bend, Hancock and Colony Park, there will be larger, I think, kind of proportionate investments that maybe we'll see forever. But as we're in this growth period, building out the facilities and staffing them up, we will see more expense there.
Is it sort of safe to say, or that we might see that as a decreasing percentage overall, or just an increasing percentage?
And
I went from
think,
16 to 22%.
I don't know where we land up. One of the things that we could calculate is where these percentages fit in terms of the base budget, and not, I don't know that it would be that high of a percentage overall, because really these are just looking at what we'd anticipated for implementing the healthcare equity plan, and what we ended up actually budgeting and estimating for and spending in 2024 and 2025.
Yeah,
Jeff?
and again, excuse me, as an increment, so Monica's right, we did have further investments in community care, so there were some costs that transitioned over. And then we had a lot of IT costs related around transitioning more to cloud-based services that were greater than we anticipated. But from a IT perspective, I think there were some investments that were made that we felt were necessary to make. And again, this is an increment of what we thought in 2023 would happen. Again, we're estimating for 2025 and then come back with, actual numbers at the end of that period. Thanks.
Do you think it's going to continue to stay at that level, or do we?
We have some further work on that. I do think that on the IT side, we'll continue to heavily invest in our systems. So I do anticipate there being an overage in that area.
One comment, Joe, when we visited University Health, their COO, Bill Phillips, said he had a rule he developed to actually invest 1/5 of CapEx in IT and data systems at University Health. So it's actually not far off the mark. Now, he was a CIO before he was a COO, so he may have a little bias there. But between Epic, between cyber and data security, I don't think we're way off the mark here, actually. It may, it just might be sort of the cost of doing business in today's age.
And Manager Valadez.
Sorry, just to add one more point, in the advent of artificial intelligence, AI, I mean, that's going to be an area that we may do some investing on the IT side, but see, multiple benefits on other areas. So,
Thank you.
Okay, Manager Valadez.
I'm not going to get into the specifics right now, but Dr. Lee, if you can recall that we received confidential information, and it specifically impacts IT department. And at some point in time, we as a board need to address that. and would like an update as to what is going on before I would hope we invest any more money
I think that's-
in that particular area.
I think that's scheduled for our June 25th meeting.
Thank you. I just want to make sure that it gets noted.
And our CIO, John Clark, is actually watching virtually. He just confirmed that 20% actually is the standard in healthcare. So,
And Chair Kitchen?
I just want to make sure I'm understanding. So the 24 plan estimate versus 24 actual, is that estimate reflecting what we originally thought back in 23, or is it the budget that we had for 24?
The 24 plan estimate it comes out of and this is where some of these, because I was born in 1969 and my brain still functions on it. I have my 20th century brain. When I look at this, I have to pull out these slides that show all of the different fields for every community need and every year in the healthcare equity plan. And so slides 4 and 5 represent what was adopted by the board in August of 2023. And then when we look at what is on slide 6 and slide 7, the plan estimate is the plan that tracks with what was in 2024 in the plan and what was in the plan that was adopted in 23 for 24 and 25. So the
Okay.
left-hand column in both of those slides is what was estimated at the time of the adoption of the plan.
Okay.
And 24 is the actual spend for 24, and then 2025, because we haven't finished the fiscal year out, that's just the estimate for that.
Okay, let me repeat it,
So
make sure I'm
the
understanding.
plan is not the adopted budget. It was the adopted plan.
Right.
And the
Yeah.
specific
That-
dollar
That's what I
amounts
wanted
for
to
those.
make clear. So, but the actual is what we spent. Do we have something, I guess that might be in another format at a different time, that compares the actual spent versus the budgeted amount? Because we've been changing our budget every year.
And
John, would I refer back
And I
to
think
our?
that is going to be part of our challenge, is with these evolutions, the budget does continue to evolve, and we can compare to what's in the most recent budgeted amounts, or we can compare to what was in the original plan. We just start to create confusion if we try to compare too many things at once. So happy to make adjustments there.
Yeah, I'm just wondering, so for fiscal year 25, we got our estimate, which is what we thought way back when we adopted it. We have where we think we're gonna get in terms of actuals, but we adopted a budget in between there. So we adopted a budget last year, and I'm just wondering if I would assume we have a different document that compares our actuals to budget, right?
Yeah, and that is in the reporting, I think that's in the financial reporting that you guys receive from Nikki and Jeff.
Yeah.
And that is actually what was budgeted in 2025 and what the actual spend for each of those line
The
items
reason,
is.
okay, I'll go back and do my homework on that. The reason I'm asking is that, we're learning from this. Every year, I assume, that we're learning from this. And so when we set our fiscal year 26 budget, we're gonna be learning from this, as opposed to going back to what we originally adopted.
Chair Kitchen, are you saying you'd like to maybe see even 3 bars per year? The plan, the budget, and the actual?
That would be the ideal.
Yeah, I think we ought to be able to take a stab at that.
If you can do that, I mean,
Yeah.
then I wouldn't have to go back and.
Yeah.
Yeah.
I take your point, yeah. That probably wouldn't add too much complexity, maybe. We'll take a stab. We'll come
check
back
into
if
that,
it
yeah.
is.
John is looking skeptical,
I
but that's
see
all right.
Some nonverbal body language here, so let me just.
Okay, see what you can do, about that.
And just to explain my body language.
Okay.
There's, I think we've got quite a few team members. There's a lot of manual matching because how we budget every year does evolve. And so something could be budgeted in care coordination, for example, in this plan in 2023, and now it's budgeted in a completely different category. So they're trying to go back and trace those out and make sure we're doing it as accurately as possible.
Okay, caveats are fine. You can put, That's right. Yes, exactly. Thank you. Okay, well, take a stab and caveat it as you need to. Okay, thank you. Oh, I also, can I say one other thing? We don't have to get into this here, because you'll probably get into it later, but I'm just noting that SUD and SDOH, we actually didn't spend in '24 or '25 what we thought we would, so. But you, I guess, are you gonna get into the reasons in each area, or are you?
I think that gets, we are, and I
Okay,
think that
well, I
that's
can
a
wait.
great example of, it's not that we invested less in substance use, it's when putting the plan together, you'll notice this as we talk through the detail, there are initiatives that show up in more than one plan area,
Okay,
but the budget ends up showing up in one or the other.
Okay.
So, to your earlier question about specialty and mental health, I think some of the mental health investments, what we call our specialty behavioral health budget now, includes the majority of our substance use treatment investment. So I think that's really what
Okay.
you're seeing there.
Yes, Manager Jones.
Does this, I want to make sure I'm clear. Does this include community care? Oh, I'm sorry, I'm looking.
It includes Central Health's payments that were made to community care. So there are some things that are part of the enterprise budget, but it doesn't include community care's entire budget. And it doesn't even include Central Health's entire budget, because this is really looking at the budget that was for the healthcare equity plan. And so that was what we budgeted for the programs to address identified gaps in community needs, over and above the baseline of services that Central Health was already providing in August of 2023.
Okay, well, thanks for explaining that, but in light of Chair Kitchen's comment about caveats, I think it would be helpful to also somehow or another break out the entire budget, including community care, the enterprise budget as such. Then which parts of those we fund completely independent of community care? And then which parts community care gets resources outside of us? Because when we talk about a health hospital district and we're having all these different caveats, one of the concerns for the public is, well, what is the agency's budget?
Yes, yes.
And so I think it would be helpful to explain as we go through the process. I don't think we need to go to all this detail, but these big captive areas, I think would be very helpful, at least for me anyway.
I think you're exactly right, Manager Jones, and that is one of the key reasons that we are integrating together. The hope is to provide a consolidated view of all of the sources and all of the uses, plan and actual, and for the board's purposes, also the potential sources and the potential uses that may not actually be in plan, but that we are looking forward as part of the overall system. So yes, we had to be able to see the big picture from a financial perspective, and that is absolutely a goal that we have. You're absolutely right.
Will we have that, I'm sorry, one Chair. Will we be able to have that by the budget time? Budget approval time?
I'm seeing body language, but that's the goal.
That's the goal.
Yeah, so now that we're talking about what the budgets are gonna look like, let's bring back the CFO.
Yeah, thank you for the question. Yes, that's the direction we're moving towards in FY '26. And so that's, you're actually kind of hitting on the format that we're looking at, which is having them separable, but then combined also.
I think that's very helpful, certainly as board members and to the community. One of the questions that were at the Manor meeting was, well, what does Central Health do? What does community care do? And who funds that and who funds? So I think it'd be helpful proactively to do that, so.
Yeah, thank you. FY '26 budget through the proposal, so that'll be, I think our first budget presentation is in July, I believe, the proposed budget. So a couple months and you know, that will be our new format of presentation.
Manager Kitchen.
I just wanted to remind myself and all of us, this is like a subset, as you know, and the reason is we've started asking questions about, because of the challenges we have with the budget this year, where are we in terms of what we thought we were gonna do with these various categories of health equity plans? So this is helping us drill down and say, these are the areas we thought we were doing, this is what our performance has been, performance from a financial perspective on these areas, which will help inform us when we get to the big picture that you're talking about, whether or not we want to adjust that, what we adopted in '23. In other words, in '23, we thought we were going to spend a certain amount on IT, to your point. And now we're learning that we're not. We're spending much more. So does that mean we want to adjust our budget or not? So this is for informational purposes, so we understand where we sit today in terms of this health equity plan. So, thanks for the detail. It's a lot of detail, but it's very helpful. So it helps me think about, well, what do we want to do going forward on IT? What do we want to do going forward on SDOH? What do we want to do going forward on all these various areas? So, thank you.
Just one other caveat.
Yeah.
Comment. We call this the health equity plan. And when we think about health equity, we usually think about populations.
Yeah.
Is there anywhere we will be able to, at some point, if not now, be able to break these down in terms of either by locations or by demographics of how we're providing services to those communities as such?
I think a lot of our next set of slides are going to give a lot more detail on what those investments were planned and what we've accomplished up to this point. It doesn't get into patient-level services. We have tried to pull in some of the key results and the budget resolution metrics to tie those in. But this presentation won't get to patient service volumes or demographic breakouts of patient volumes, but we can certainly pick that up in other presentations.
Well, and it does when we get to, if we get to slide 30, we have Sarita here to do an update on the key performance indicators. And that does include some information on volumes and in terms of services for people with diabetes and hypertension and control of those particular. If you look at when we get to slides 38 and 39 and 40 and 41, that does look at those illnesses and specific populations and demographics of populations and how we're addressing those illnesses as a year over year as an indicator, outcome indicator of how we're performing on the healthcare equity plan. And so that will be updating, that's at the end of this presentation.
Just one quick one.
Cynthia.
Just one quick one, and I think it's because I thought I heard Sharon talking about the possibility of a new in-house entity that was going to be created that would be able to track the billings and the services that were being provided and the amounts of money in-house. Yes, the TPA, yes. And that would be able to give us an exact picture of what we were doing with our money to what population or in what areas, even broken out by the 10 or 15 specific categories, medical categories. Is that correct? But that, I don't know when that is going to be in place.
So
But I know that that's
are you
something that
referring
they're
to the
working on with
third-party
you all, I'm
administrator?
assuming.
The claims adjudication?
Yes,
So-
yes.
So that is an example of something that was not specifically identified in the plan, but was something that the board approved to move forward on. And to Chair Kitchen's point, this is the original plan, you know, the plan evolves and the board's,
Iterations,
you know,
And-
annual update to the budget is what we work from. We process claims, just like Sendero does, for the MAP and MAP Basic programs through that TPA function, and it is a significant part of our analytics capabilities. So it's one of the sources that we use to get that utilization data or the demographic information on our utilization. Yes, ma'am.
Okay, so can we go ahead to slide 13? And I'm going to hand this off to Dr. Shawsha.
Thank you.
Oh, and during the next part of the presentation, we will be going through, and this, Jeff will come back for some of this, but we've got about 15 slides where we go into detail the actual progress that we've made in implementing the program by fiscal year.
All right.
Thank you, sorry.
All right. Good afternoon, Dr. Brinson, Chair Kitchen. We're looking for the specialty slide. All right. Want to start with just a thank you. This is an opportunity for us to really talk about the services, the support that you all gave towards our health equity plan, so our strategic plan, and all the initiatives that then fall under that strategic plan. We're going to be going strategic initiative by strategic initiative. We're not going to speak to every line of the slide, but we're going to speak to many of them. Again, this is our opportunity to really share with the board the work that our teams have been engaged in, and ultimately the care that has been delivered to the communities we serve. The initial community initiative is specialty care that I'm going to start on, and this is both for direct services and for contracted services. If you remember, Monica explained that the stars within the slides are services that we didn't plan at the beginning of the year. It's either a new initiative or an emerging opportunity that has appeared. And I think this is easiest illustrated if we speak about the opening of our first clinic. Because our first clinic was supposed to be RZ, right? Due to supply chain challenges, RZ didn't open in time, and so we took the opportunity to utilize the other side of the East Clinic, which is, was being currently utilized by community care, and we started our specialty care in that clinic, first with podiatric services, then with GI services, then with pulmonary services, and then we outgrew that clinic. So we needed a second clinic. RZ wasn't ready at that point. So we opened Capitol Plaza and continued the build out. GI, pulmonary, nephrology, supportive and palliative care, wound care, hepatology, infectious disease, and cardiology jumped on board right at the end of the year. We increased access to endocrinology by way of contractual means and also started endocrinology planning. All along, we had continued to plan and design Hancock, which is obviously going to be, I think, about 100,000 square feet of clinical space. Any service line that we opened, we needed to ensure that our patients had access to durable medical equipment. I think podiatry is a great example, whether it's scooters, whether it's walking boots, casts, splints, wound care supplies. And so, DME expansion was critical to any service line that was opened. We also started planning for our justice-involved community and really looking at what their critical needs were related to specialty, and that started in '24. Workforce development, our partnership with ACC initiated then. Proud to say that we've had 4 cohorts graduate since then. We've had 36 graduates, 33 that have passed the certification. We've had 11 direct MA hires by Central Health, 9 by Community Care, and 1 by Peoples, right? So we really are helping support kind of the build internally. Tubal ligations, both direct care and contracted care was initiated that year. And then in order to meet our patients where they are, we looked to provide remote access for patients in the service lines of behavioral health, dietitian access, and pharmacy. We continued to build on our dialysis program, which kicked off in 2022 and then gained speed in 23 and 24. For FY25, that's when RZ really came online, and we continued the build-out of RZ. We continued the construction and build-out of Hancock, and then the CEC design and build-out started there. As a reminder, and we're going to touch on this when we hit each service line, CEC will house between 40 and 50 respite patients. Along with those respite patients, we're going to build a general clinic that will provide access for specialty care, the PM&R, PT, and other services. And so a lot of planning has gone into that. And that service line should open, I think July 23rd is the planned date for that. We established ENT services, and rheumatology goes live within the month. Continued to expand access for ambulatory surgery centers, contracted for increased access for anesthesia services, continued to expand GI, sleep studies, and again, durable medical equipment. We've done significant planning related to graduate medical education and undergraduate medical education. Some of that is dependent on us, and some of that is dependent on partners. And so we can dive into that more at another time. Again, this is critically important to expand this service line as we continue to work on workforce development, growing our own, ensuring that folks are culturally engaged, appropriate, and learn with our teams, and keeping them home is something that's really important to us. The RN externship program initiated. I think in the next month, we're going to have 4 nurse residents who will graduate from our program. All of those nurse residents will stay home and continue with us. Endocrinology will kick off within the next month. And then we have done significant planning with Community Care as far as the launch of our dermatology services. Those services, I'm just going to go to FY26, and as we move along, so you'll see, we go from very specific to more general and more planning, and as we move through the years, the green arrows will indicate really creating and investing in bench strength. I think we've shared with you all multiple times that we set up multiple service lines, but our service lines are not deep. They're wide, and so we really need to build bench strength as we continue to build out. FY26 continued to scale our specialty services. Hancock will open specifically. David Powell will move into that space. Pharmacy services and same-day services will really be the initial programs, along with primary care, that will open there. Dermatology should go live near the beginning of the calendar year. And then we will need to bring this back to you all, but we will talk to you all more in the future about optometric services and hearing aids. Some of the voucher programs that have sustained our patients in the past are going away. And so we will need to be building on those in the future. Med gap coverage, there are still gaps in care for our patients as far as their meds, and so we'll continue to build that out. And then PT, OT, and some of the other therapies we will work on moving forward. Next slide, please. I think there've been multiple requests as far as by service line, what do our visits look like? So here's an example of our status by visits. Do want to share that what's represented at the bottom is the service line, but it doesn't necessarily represent a full-time FTE, right? From the very start of FY '25, let's use our Bridge Clinic as an example. When Bridge started with a half-day a week presence, and then we built up to five days a week. And so as we scale, so you'll see the numbers increase, and we are gaining momentum, and month by month, our visits are increasing and our folks are getting busier. All right, next slide, please. All right, our next initiative, community initiative, is access to mental health. Again, this is for direct practice and for contracted services. We continue to expand access through our partner Integral Care by contracting with them. We contracted and worked with partners to increase access for those individuals being diverted by way of psychiatric emergency services. I think we went to the 23-hour ops and prescribers throughout that 24-hour period. We hired our behavioral health manager and our psychiatric director and continued to build out and design those services. Again, you can see a star here. This is something that we didn't initially, the African American Youth Harvest Foundation, not necessarily an initiative that at the beginning of the year was that we were planning for, but there was critical need here. These services really cater to families and children impacted by trauma, and so we've continued to expand our contract with the African American Youth Harvest Foundation. We also did significant planning as related to the ASH campus, and that work was done in collaboration with partners. For FY 2025, psychiatric services went live, and we continued to expand them specifically at our skilled nursing facilities. We added remote access to both psychiatric services and to some of our counseling services. And behavioral health also went live within our SNF. We launched, and this is the funding of Integral Care, permanent supportive housing services. And this is independent of us, providing medical care. This is the mental health care aspect of that. We established M3 services, and M3 services are both mental health services and physical health services to individuals who are unhoused, who have a mental health diagnosis, who have an addiction disorder, and at least 2 physical health diagnoses. And we continued supporting Integral Care at our PSH facilities. We also provided the initial medical health teams at our PSH facilities, and have now, as of next month, actually we'll be handing that off to Community Care, who will then continue to provide those services. The ASH campus planning continued, and we have continued to sit with partners, Integral Care and UT, as far as the planning of the care continuum. Not a fast process, but a critical process to understand what each organization's paradigm is. And so we're bringing those together, finding where commonalities are, and really starting to discuss which patients, would best succeed in which environments. Lots still to do in that area. Peer support, we're looking at investing in peer support in multiple areas. These are individuals who have lived experience, and there's a lot of good evidence that really speak to the fact that patients do much better when they are supported by individuals, with a similar experience to themselves. And so we're undergoing planning in that area and have budgeted for positions within this fiscal year and moving forward to FY26. We've expanded psychiatric and behavioral health access within our UT environment. And one of the advantages here is when we think about UT, they're able to hire some of the subspecialists. And so individuals who specialize, let's say, in bipolar disorder, and it really meets our patients' needs, we could provide some of the generalist access and then partner with UT for some of that subspecialty access. We've contracted and we're adding psychiatric and counseling services at Austin Child Guidance Center and peer recovery specialist services through the Sims Foundation. For our services moving forward, again, we need to gain some bench strength. Hiring psychiatrists is actually pretty difficult. Many psychiatrists are used to remote work, and that may work for some of our patients. It doesn't work for many of our patients. Many of our patients are unhoused or are in the shelters, who live on the streets. Having a person in person actually best meets the needs of our patients. So it is challenging to hire mission-aligned, qualified psychiatrists who are okay being on site and serving our patient population. Next slide, please. All right, this initiative is really looking at our post-acute environments. We've spoken before as related to the respite beds. Again, we started with I think 5 respite beds. We built up to about 25 respite beds, and we'll hold constant throughout most of this year. I think, as I said before, January or July 23rd is when we will have our first owned and operated respite beds come online. And so you look at some of the metrics for last fiscal year, we had 6,700 bed days that were occupied. So number of respite beds times the number of days that they were available. We're going to get close to that this year because there's not going to be a ton more beds, respite beds that were online, but the beds that will come online in July will be added to the contracted beds. So there will be more opportunity moving forward. In FY24, we started the Cameron Road planning and started the planning of our bridge program. Skilled nursing service, our skilled nursing service went live, and I think we learned a lot in that first year as far as, when should we conduct our first on-site evaluation of our patient? When should their plan of care be delineated? When should we do multidisciplinary rounds? How many touches do our patients need? Is there translation services? And so we've got a standard operating procedure now and a kind of a standard of care. And so lots of lessons learned within that first year that are now being reinvested as we grow more mature in our processes.
May I interrupt you, please? Kind of going back to the issue of psychiatry, which segues.
Yeah.
I mean, as a practicing primary care doctor, it's a near impossibility to find a psychiatrist who will see patients. How much are we trying to emphasize that primary care doctors assume that role, which is what happens in the general practicing community? I mean, there's an enormous need for psychiatric services. I think it's rare that a specialist per se will be needed, except for rare medical management, perhaps. And how much are primary care doctors being sort of asked to do some of that?
I think right now they're being asked to do quite a bit of it. I think community care is using advanced practice providers as well in that space. There's not enough access. There's not enough access at UT. There's not enough access at Integral Care. There's not enough access within our primary care partners and with us. And so I think your question is perfect, because what's appropriate for primary care and what primary care providers also have the time to care for in a 20-minute visit doesn't allow for a ton of therapy. And so I think what we're working on now, with Nick and his team, with Integral Care and with UT, is really trying to figure out what is appropriate in which environments, and what are the models of care that would cater to those patients best. We don't have an answer yet, but the good news is that everybody is showing their cards, and we're in active discussion, as well as looking at the care model that sits within our primary care environment and challenging what that currently is so that we can increase access. I think Pat has spoken to the fact that we're trying to make next year the year of access, and that includes specialties as well as primary care. And that means the current models of care that we have are not sustainable. Yeah.
Can I,
Just
can I
add a
speak to
little-
that for a minute? Oops. Can I speak? I just wanted to let everybody know that, as y'all have, as you just said, this, planning is occurring with the partners you just mentioned. What we're targeting is an October meeting, October board meeting between our board and Integral Care's board. Hoping that by that time, well, you guys may not be finished, but by that time you can provide us, you and the Integral Care team can provide us your initial thinking at least about the system of care. And as you just said, in what environment should the patient be served? Because I think the goal here is we've got key partners in the community, Integral Care, CUC and UT also. And we need to figure out where the patient can best be served, and also make sure that we're not tripping over each other, that we're not building things that duplicate, and that we're not building things that really should sit in other places. So now October's a while away, and there'll be conversations between now and then, but I think that that's at least one marker for us to, as boards, to talk with the Integral Care Board and try to get some more of an understanding of what direction we're going in. So I just want to let everybody know that. We've talked to the chair of the Integral Care Board, the CEO of Integral Care, and with Dr. Lee and his team, and identified October as the timeline for doing that. So.
If I could just add a little
And
more.
just-
Oh,
I just
please.
wanted to follow up with
Can
I just want to follow up with Ann real quickly on that kitchen, Ann Kitchen, on that very question. What are we doing in communicating with the other districts and those that are doing this work in the nation, so that we can bring in what best practices are being recommended, or what they're proving to show, and not have to reinvent the wheel. So I just wanted to make sure, I know y'all are doing that, but I just want to make sure that we can, as a board, know that we have assurances that we're not looking at
Could I build on
wasting
that
time.
exact point, Manager Valdez? Just by pure chance, for 4 years I was at Lincombe Health Center, Massachusetts, which is a real outlier. At Lynn, there are 2 behavioral health professionals for every 1 primary care professional. It's a 2-to-1 ratio. And it's the only time in my professional life that I felt like I had the behavioral health support I actually needed in primary care. I'd be practicing on a room flanked by 2 behavior providers, and literally in real time, not just, you're about to commit suicide, but you are from an equatorial country, spending your first winter in Massachusetts apart from all of your loved ones, and diabetes is the last thing on your mind. And let me get you somebody who can help you adjust, right, and take care of yourself. So there are radically different models out there than what I've seen almost anywhere else in the country, but they exist. And the challenging part is how to make the finances work and find good people. But yes, I think part of our work will be to really expand the frame and ask, what do our patients really, really need? And where do we put that investment?
Okay, Manager Jones.
Yes, my question goes to a sort of a bigger picture, and that is the question of, we're giving $35 million to a medical school here. And what I'm hearing from you all and from other places is that we're not getting any bang for our bucks. Now, I understand the politics of, well, it wasn't explained that way, it wasn't understood that way. But I think we need to revisit this question at some point, because if we're not going to have providers, why are we continually paid this amount of money? At our town hall meeting in Maynard the other day, there was a young lady who was a student at the Dell Medical School. She was only one of, I think, 3 African-American students in the whole school. But one of the things she made very clearly is that, oh, I didn't realize we had the opportunity to do work with you all on some of these things, on our initiatives. And I'm just trying to say, I'm not sure how much communication is going on. One, how much commitment is being made. And I think somehow or another, we need to elevate this to the elected officials, but maybe even to the public itself, as to the challenges we are facing in terms of providing care, because we spending $35 million a year, but we're not getting the results of it. And so I just get frustrated hearing this all of the time, knowing that we're putting that type of money into a medical school that I'm not saying it's not doing anything, but I don't think we're getting the $35 million it's worth.
And Manager Jones, I'll try to respond to some of what you're describing. In addition to psychiatry being difficult for us to, it's one of our hardest areas to recruit, but it doesn't mean that we're not going to continue recruiting. We've got to get more creative, and I think we are. One of the places that the medical school helps us, and I think helps Integral Care too, is in co-recruits. There are, in co-recruiting physicians, and Integral Care, UT has psychiatry faculty and residents that are in the Integral Care environment, and we're in conversations with UT around how we can collaborate. Psychiatry residents are the first area that we are trying to prioritize with Ascension, to have psychiatry residents able to rotate in our clinical environments, so we can establish those relationships and hopefully keep more of those residents here in the local community. Another strategy I think we're employing is it is significantly easier, although it's not easy at all, but it's much easier to recruit a psychiatric APP than it is a psychiatrist. So we are trying to maximize recruitment opportunities with psych nurse practitioners in our space as well, to help supplement that access. Hiring counselors, clinical social workers, is also a significant challenge for us and for Integral Care, all of our partners. And so it goes back to becoming an employer of choice for those individuals. In our practice environment, it means developing more virtual capabilities where it's appropriate, so that we can offer some remote work type opportunities for certain environments. But then building out that workforce pipeline, whether it's for counselors or whether it's for physicians and residents coming out of the medical school. So those are all active conversations, and the leadership of the psych department at the med school have been really closely working with us.
The other thing I would say is that we have been able to recruit. It's just very difficult. There's one area we have not been able to recruit, and that is neurology. Other than that, every other environment we have recruited. The other thing we're doing, and I mean, we're trying to leave, we're trying to do everything we can to engage with the medical students and the residents early on. As an example, when the new class of medical students start in July, we will be in front of them in general orientation, sharing who we are, what we do, as well as all of the medical students, about 250 residents, rotate through community care. And this is why the care model is critically important, because we need to ensure that they have an experience that really invested in their education so that they want to stay home. So we have lots of opportunities, and we are working well with them. There's just significant more opportunities that lie ahead.
And I'm not questioning what you all are doing. I think you're doing a fantastic job. I'm questioning the concept that was put in place, that this is what we're going to use our taxpayers for. And if what I'm hearing you saying, we're having some success in getting them involved, then the question then becomes, why are we at where we are? we've been at this, when was that amendment put in the budget?
7 years old.
2012. So we've been at this, what, 13 some odd years, and we find ourselves still there. And it's frustrating. And I think it would be frustrating to the Commissioners Court and to the citizens of Travis County to know that we're doing what we can, but we can't guarantee that we're going to get $35 million worth of investment for our population.
I think you're, oh, yeah, go ahead. I think you're highlighting an issue we have identified, and I think it's an important conversation. I know we do have, I believe it's in July, is our annual report from DelMed to our board. And we can have some conversation at that, and perhaps that there, we can do some pre-work about that. I know that you all have been working with UT and have been working, let me back up for just a minute, and then we'll get into more details in July. You know, the Commissioners Court passed, I'll call it a resolution, I don't know if it was a resolution, but had to do with, I know, it was a revision to their accounting, their financial policies. And those financial policies included some reference to information about the finances related to DelMed. So we have that. I know that you all as staff have been working with UT, DelMed to try to address those. So perhaps it would be appropriate in our July meeting or even our June meeting to go over that so that we can be prepared when we have our annual report from them. Does that make sense to you?
Yes, it would be helpful for me to have
Okay.
a picture of that myself. I don't know
Does
about
that
anyone
make
else.
sense, Dr. Lee? Okay.
May I add to
Yeah.
that? It is on. I'm wondering if it would be of benefit to ask the UT folks, whoever is in charge of this program, to come have a candid conversation with us.
Okay.
It's kind of similar as what we've been trying to do with community care, what hopefully we're going to do now with integral care.
Yeah.
Because they are indeed a major partner, and as we know, the dissatisfaction and the lack of information and lack of understanding of what's the programs are benefiting us and so forth. And the will for us to continue to fund them, of course, is there, we have to by law, but we're the ones that take the heat, right? And it would behoove us to have an open conversation with them so that they can understand our challenges, kind of similar to what Manager Jones was referencing. Because they don't get to see that. They're not out in the community like we are, like we're doing these sessions, you know, that we just finished. So I'd like to offer that as a suggestion if y'all think it's worthwhile.
I would just
think it makes sense.
advocate to that is we've had them before.
Okay.
Not to the level of what you're talking about, so I agree with you, but, you know, I don't want to get us to keep running, you know, coming in here, you know, smiling and grinning at our
Right,
face.
that's what I'm trying to
and
avoid.
going around doing-
Because we had that presentation last summer and, yeah, and I'm trying
You
to
want this to
take
be
this a little
different this
deeper.
time, yeah. Okay, I'm hearing what you all are suggesting. I'll work with our vice chair and with Dr. Lee to make that a meaningful conversation in July. Okay,
The only aspect that I was hoping to stress with this, and then we'll go back to post-acute, is, you know, UT is the sponsoring academic institution, but GME is owned by Ascension. And if you think about, you know, the med students, there are 50 med students, and they can spend a lot of time in our environment, and then they have 3 to 4 years of training that is post our environment that right now, we don't have any control of the GME and of the residents. We actually want those residents in our space. That is not up to UT right now. The more they spend time in our space, the more we can then hire them when they're finished their graduate medical education. And so that's a big piece that's missing that UT doesn't have control of right now. All right?
okay.
I'll
Ascension
go
fund.
back to, that is Ascension. GME is controlled by Ascension.
Yeah, let's move back.
All right, back to post-acute? All right. So FY '25, obviously, we're going to continue to invest in our post-acute teams, both respite and SNF. Those are the clinical teams, continue our Cameron Road planning. The CEC is coming live within a month or so. We're also expanding our SNF team. We're adding a fourth team, and that is to a fourth skilled nursing facility. And so additional patients will be able to be cared for by our teams. We are starting inpatient rehab planning. We know that there's a critical need to cater to our patients the way we are within our skilled nursing facilities, and so we're engaged in planning there. Also looking at continuing to expand our bridge and mobile, and then ensuring that, 24 hours a day, our skilled nursing facility patients and those in respite have access to the clinical and social needs that they have. FY26, continuing the expansion of all of the environments that I have stated previously. There is an organization that really carries the subject matter expertise as related to justice-involved individuals, and that is our Transitions Clinic Network. We'll be contracting with them in collaboration with CUC. We were talking to Drs. Martin and Brinson yesterday about individuals who are incarcerated. The first few days post-incarceration, there is a significant risk of overdose. And so transitions of care post them being incarcerated is critically important that we get that right. And so we'll be contracting with this organization who does it better than anybody in the country as we continue to build out that care. We will also be looking at skilled nursing facilities and reimbursement that is specific to hospital districts and opportunities that we may have. And so Jeff continues to work on that and then look at inpatient rehab opportunities. Just one metric that I did want to cite. So far within this fiscal year, we've had 256 patient episodes, and it's patient episodes, not necessarily patients, because a patient may be discharged from a skilled nursing facility and come back to the skilled nursing facility at some time later. I think the average length of stay within our skilled nursing facilities is about 20 days. Next slide, please. All right. We are now talking community initiative within, this is primary care, HIV, and convenient and urgent care. FY24, Hornsby Bend Clinic opened. We continue to invest in CUC as far as them increasing access for their mobile teams. Continued investing in access to pharmaceuticals. We initiated our partnership with the Black Men's Health Clinic and CUC. And in FY25, 771 patients had been seen. I think that's as of about 2 weeks ago. So those are unique individuals. FY25 continued to expand what I previously mentioned. Continue to talk about different models of care. CUC is working on increasing their same-day access. They've done so to date. And again, we're talking in partnership with them about what new models of care may be. Programming services really have kicked off for Colony Park. We've added a new provider to support HIV access. And then obviously launched additional bridge and mobile teams. Del Valley, I think you saw a little earlier today, kind of the celebration with the opening of the Del Valley Clinic. In FY26, we're looking north and south in the Runberg area. We have our highest concentration of patients, of individuals who fall within our demographics that we serve. We're looking as to how we can build access for them close to where they live. What we see is that patients are traveling to North Central and to Southeast. So our mainstay, large primary care clinics. We're also looking at the South Clinic within CUC and looking at partnership opportunities with them. That clinic is not in good repair, and there's significant opportunity to expand those access points. Once Hancock is opened, the David Powell Clinic, same-day care and pharmacy services will move into that clinic, and then we will continue to build out those services. We're also talking to CUC about what a CareCo 2 means. Their CareCo clinic is a clinic that serves complex individuals where wrapped services really serve the patient best. If you think about our Bridge Clinic, if our Bridge Clinic was a transitional clinic for many of these patients, where can we serve them when they actually have a primary care home? It would be in that type of clinic, yet that is where they stay. One of the care models we're looking at is that our Bridge Clinic serves at that transitional clinic, so EMS, the shelters are really the source of those patients, and once they're stabilized, they then transition into CareCo. Next slide, please. And may celebrate, this is the last slide for me, and then you have to listen to John Morgan from this point on. The Community Need Initiative, this is really addiction disorder services, and if folks are listening to NPR, really want to celebrate the fact that overdoses have decreased over the past three years. This is multifactorial. I would hope to think that our efforts play a small part in that, and we're going to talk about some of that, but our communities are better off now than they were, let's say, 3 years ago, where we were really suffering this opioid addiction epidemic and all these tragic overdoses. We, in FY24, really expanded contracting with CMS and with Oshbach and Associates. These are environments where our patients can attain Suboxone and Methadone. We also started our partnership with the Sobering Center and started really accessing or providing access for our patients to holdover beds. Happy to say that partnership is growing significantly, and we're going to continue working with the Sobering Center. In FY 2025, we built out the Capitol Plaza, where we have our bridge and mobile team, and there was an opportunity for CUC to expand their access to Suboxone with what we are now calling WHAM, which is Wellness Holistic Addiction Medicine, which is again wrapped care for individuals who have an addiction disorder. That works beautifully, having kind of our bridge clinic in the same environment where we've got addiction disorder access and those wrapped services, and those teams I think work hand in hand with each other, so it's working really well. We are looking to recruit addiction disorder additional leadership. I think probably a year ago you all heard from John Weems, and at some point hopefully we can bring Dr. Weems back to present to the board. He's a subject matter expert, he's Harvard educated, has as big a heart as he does brain, and really he's serving as kind of what Dr. Lee described as a chief engineer in the design of the system. We do need more personnel in that addiction area, both within Central Health and within CUC, and just to continue to kind of walk together and work as one service line. We were able to distribute naloxone this past year. If anybody's walked into the airport environment, as you walk into that Quarry Lake exam room, you walk by what looks like the old newspaper dispenser machines where you pull down, the front lid or front opening, and you can take the newspaper. Mm-hmm. Now you can take a naloxone, and those have been distributed, throughout many of the CUC clinics. We also have vending machines. So if you look outside the CUC, there's a vending machine that's temperature controlled where individuals can access naloxone. We worked with our EMS partners and with many of the shelters, and we've distributed over 1,800 naloxone units. And we'll continue to do so. We have provided care, medical care by way of our bridge teams to the 15th Street pilot diversion sites, and are continuing to expand our holdover beds with Sobering Center and talking to them about, what long-term partnership looks like in that environment. We are looking at contracting for additional detox opportunities. It's very hard to find kind of inpatient detox here in Austin. And so we'll be contracting for those services and continue to expand access to methadone. FY26, continue our joint planning and programming with Partners for Addiction Disorder Services, and continuing to plan within towards our Cameron Road center that will offer increased access to respite bed, and we're looking at what would be most appropriate on that campus related to detox services. So that planning is underway now. And I think with that, I will hand it off to Mr. Morgan here.
One last thing I'll point out on substance use treatment is we're fortunate to have access to some additional funding through the opioid settlement dollars to continue making additional investments. So even though our investments are higher, we do have a additional source of revenue. And I think as we bring the FY26 budget forward, you'll see that we'll shift some expenses into that new budget resource that's been brought in. Next slide, please. So this community need is our access to hospital care. Primarily, our plan consisted of the investments in our hospital-based transitions of care teams. These are our teams working in the hospital on a daily basis, helping to do discharge planning and transition our patients into skilled nursing, into respite facilities, to home and back to primary care. Really hard to overstate the impact of doing those warm handoffs for the 850 people so far this year that our teams have really helped navigate that on a customized individual basis. There are also teams in the emergency department that are helping to transition and connect patients to follow-on care from being in the ED. And then we have some significant investments that Alan spoke to briefly around the sexual and reproductive health services that cannot be offered through our Ascension partners due to the ethical and religious directives of the Catholic Healthcare Organization. So we're fortunate that a few years ago we had very little access to tubal ligation procedures for our patients, and we're now providing those services through People's Community Clinic, Lone Star Circle of Care, directly here at Central Health, our partners at UT, all contributing to that network of options for our patients. We've also been able to contract with 2 providers, and one of which being the University of Texas, to add vasectomies as an available service for our patients, and that was a missing service in our scope for several years. We're also going to continue to do work related to closing gaps in hospital services related to our ongoing litigation. Our assumption in the plan was that a significant portion of that work would also continue beyond the 7-year planning timeline. Next slide. So this area is related to our healthcare for the homeless services, and again, as I mentioned earlier, our budget doesn't include a healthcare for the homeless specific budget, but we tried to carve out and identify those specific initiatives that were identified in the plan and give you that comparison here, even though it's not something that you've seen before in the monthly financial statements. So our plan primarily consisted of adding additional bridge and mobile team capacity. This was one of the several initiatives that I think the board and the Commissioners Court at the time really encouraged us to look for opportunities to expedite and bring services on faster than what we had even put in the plan. So over the course of, well, I'll talk more about what we're doing. Let me finish telling you what was in the plan, I guess. So the plan was primarily additional mobile services, both internally here at Central Health and through our partners. Diversion services, those are services that are right now primarily arranged for in collaboration with community care and integral care. And then adding additional SOAR eligibility capacities. So these are the eligibility services team members that are helping our complex patients experiencing homelessness navigate the Medicaid and disability processes, and getting those individuals access both to a ongoing monthly income as well as healthcare coverage through Medicaid. And then expansion of targeted enrollment specifically for individuals experiencing homelessness. As you all know, we've transitioned quite a bit to virtual and telephonic means for enrollment, but that's not always going to work well for all of our patients. So we're really trying to embed and create more access points for face-to-face enrollment and walk-in enrollment opportunities for individuals experiencing homelessness. And then Alan spoke to this briefly as well, but expansion of our high-risk clinic capacities. So this is, the Arch Clinic, the CareCo Clinic, Complex Primary Care Clinic at Community Care, and our Respite Clinic at the CEC. So I'll just hit a few highlights for work that has taken place in relation to that plan. Our Respite Clinic went live at Capitol Plaza, serving the patients that were staying in our contracted respite environment. As the CEC opens next month, it's going to transition over to the CEC. So we've got all of those services right there in the building. We have continued to expand, to the extent possible, the contracted respite capacity in the community, but it's been limited. Partners like the Arch, working with the city at the marshaling yard, a new entry, Fresh Start, the Parsons House are all examples of where we have respite bed capacity in the community. Expanding both the community care street medicine team, and as I started to say earlier, we actually brought on mobile teams earlier than our plan anticipated. They were really planned, I think, for FY26 or 27, and we started the planning for those teams back in 24 and actually brought those on in the past 12 months. And we're really excited about the progress that's been made there. We also, in this space related to individuals experiencing homelessness, I think there's certainly a direct connection to the services provided by Integral Care in that last bullet of the FY24 achievements. For this current year, again, the respite facility opening at CEC with clinical services and continuing to support the permanent supportive housing facilities that are coming online. This is a big driver, I think, for the timeline of our clinical services build, because as we bring on more permanent supportive housing in the community, these are complex, medically, socially, individuals that are being placed in these housing units, and we want to make sure that they're successful in their housing by having comprehensive medical supports and case management supports. So even this year, we are having lots of conversations with multiple partners, just a few that are highlighted here, the Community First Village with foundation communities, with family elder care. We're starting really with a case management and navigation approach, but as we're able to bring on more mobile units, we're able to provide medical services on site to support those individuals in the PSH locations. We think over the next few years, the housing partners in the community are going to bring on about 2,000 additional units. And there are going to be some dedicated PSH sites, some that are more scattered PSH vouchers and other facilities, and we really want to create a network of mobile services to support those individuals. We're also excited to now be participating in the HMIS system that is the Homeless Management Services, their navigation system that helps with coordination and with placing individuals in housing. So our Central Health teams are now actively involved in that. And I think you've heard a little bit about this, but we've been able to secure our initial 10 beds of permanent supportive housing through a multi-partner collaboration with Family Elder Care, with ECHO, so that as individuals are leaving our environment and respite, they are discharging from respite into housing and not having to discharge to the street. So that's just the beginning. There's a lot more that needs to happen in that space.
Can I ask about that?
Sorry?
That's fabulous. So can I ask you a question about this?
Yes, ma'am. please.
So, what does that mean? Does that mean, can you give me a little bit more detail? Does that mean that, that they will hold beds for us, or how does that work?
There's a lot of work behind the scenes, and I probably won't do it all justice. But,
Okay,
Dr. Mercer, who I think you all have met,
Yeah.
who leads our Bridge Mobile M3 teams, is now part of the council. What's the council at ECHO?
It's the coordinating,
Coordinated
Coordinating,
care.
yeah.
The COC.
I always forget the
It's
name of it.
It's the body that
Yes.
oversees the coordinated
Right.
entry process. I'm sorry, I can't remember the name of it, but, so
Mm-hmm.
Dr. Mercer's working and Dr. Audrey Kwong is working with ECHO and the other partners that oversee that process to really create some dedicated capacity by creating a specific population within the HUD eligibility criteria for individuals in respite. Just
Okay.
like there are specific housing vouchers for VA, for, other,
People who have been, people who have experienced domestic violence, that,
Yeah.
there are specific vouchers for specific populations.
So that doesn't give us the bricks and mortar unit, it puts us on the list. For a voucher.
It creates a unique list for individuals that are coming out of respite facilities. Family Elder Care has allocated 10 beds specifically for
Okay, that's
that.
what I was wondering.
And so we got to change the process with ECHO and the coordinated entry side. We've got to
Okay.
work with the housing providers and link all of that together. So that's I think, a first kind of early win in that space. But
Okay,
as we've talked about before, we probably need several hundred units in order to really
Yeah.
create the throughput out of the respite environment that we're going to need.
okay. Well, thank you, that's a good start. One last question, then you can give us the nitty-gritty later. Is that age-related for family elder care?
It is not. There's no age
Okay, good.
restriction on those beds. No.
Okay,
We also have additional access for another 10 beds, working really closely with Mobile Lobes and Fishes and
Okay.
Alan Graham. And so both of those, we haven't even shared this with Pat yet, but both of those should go live with 2 to 3 beds starting in July.
Okay.
An additional 2 to 3 beds in August. And by October, the hope, and Audrey and Tim are not going to be happy that I'm sharing this, but the hope is that by October, we are 10 and 10.
okay. Yes,
Community first.
yeah, no,
Yeah,
that,
yes.
Off
that-
Hog Eye? Yes, ma'am.
not everybody be eligible for Community First because they have
Correct.
specific eligibility requirements. Family elder care is probably more broad, but should be very helpful, so.
We need lots of options, so we're really talking with anybody that can help
a good
create
start.
part of the solution. And to your point, we've got to make sure that we get the right patients in the right
Well, they
environment
won't,
based on their
Community First
needs.
won't accept people that don't meet their criteria, which is
Understood.
fine. But 10 and 10 is that, so 20 dedicated, if we can make sure they're dedicated and they save them for us.
Mm-hmm.
But you should, well, anyway, this is exactly what we've been talking about, and so that's good initial work to get started. So, thanks for sharing that.
Absolutely. So just to highlight some of the FY '26 upcoming proposals in the budget process, we're really proposing 3 additional teams to add to the group of mobile teams serving our patients out in the community. And this is to service a variety of locations. So some of the PSH locations, the shelter environments, some street medicine and serving people where they are, as well as working with our justice-involved population as well. So, and some partner partner locations and actually bringing medical services on site there. As Alan mentioned, continuing from the case management model, but continuing to evolve and build with these partners over time, including Family Elder Care and the Community First Village. We're also looking at opportunities related to our Cameron Road facility. As soon as we're in the Clinical Education Center and go live with respite services there, we're going to be turning our attention to the design and build for that Cameron Road opportunity. And one of the things we really want to try to capitalize on is making sure that it's a one-stop shop and hub for both healthcare and social service connections for our patients that are residing there. So working with our partners to make sure that we can get as many services on site under the roof there at Cameron Road as possible. And then continuing our investments, we're fortunate to have that additional opioid settlement funding to continue investing in substance use treatment and naloxone distribution. Our big effort still for the rest of this calendar year and into next year is adding additional capacity for residential treatment services and detox. Those are both significant gaps that we have in the community today. I should also mention our work with Austin Travis County EMS is continuing to mature and evolve. As you all are aware, we transitioned from reimbursing EMS for transporting patients to actually providing services throughout the community. This is their C4 team, the community health paramedics. They're doing opioid treatment inductions on the street and connecting those patients to ongoing treatment at community care. And lots of opportunity to continue working with EMS, but also coordinate the EMS provided services with the integral care provided services, so that we've got some really good definition in who's doing what, and some deliberate handoffs between organizations where appropriate. All right, next slide. Okay, so this community need is around expanding access to dental care. So our plan here largely consisted of adding dental capacity, and it's really through a combination of contracted partners as well as significant capital investments that you all have made to add capacity in our system. There's really a trade-off there of contracted services may come more quickly, but we can either pay additional contracted service amounts, or we can have those dollars contribute to long-term infrastructure that's dedicated to serving the safety net. So we try to strike the right balance there, and we've done quite a bit of both over the past couple of years. But these are capital-intensive projects, they're time-intensive projects, and take quite a bit of time to come online. In FY24, there is dental capacity as part of the Del Valley opening that just recently took place, the grand opening. We have done a significant expansion of oral surgery for our patients. There's a significant need, and that dental services as a whole is a great example in my mind of it's really hard to estimate demand until you have adequate capacity and supply. And this is a great example where we have yet to find the point where we are at risk of building more supply than is needed. The challenge here is Central Health is the primary entity that reimburses and covers adult dental services. There aren't a lot of other programs out there that are doing that. So we have added oral surgery contracts. We've added a partnership with Manos de Cristo, who serves a significant portion of our patient population. And then dental services are going to be part of the programming that's planned for the Colony Park development. Another more specialized service that we've been lacking and we're super excited to have access to today are pediatric sedated dental services. We're still working on adult sedated dental services where that's needed outside of oral surgery, but we're continuing to expand both our contracted and direct practice areas in partnership with community care. We're excited for FY '26. We do a lot of dentures, and we're looking at opportunities to bring dentures in-house at community care and also with our other FQHC partners so that our patients aren't having to go outside of their primary care home to access that service. So we're excited to work with our partners on that part. And then, as I said, we've still got work to do in this space as we're looking at the opportunities that Dr. Shalsha mentioned for the North Austin and Runberg areas as well as South Austin. I think we'll look at what opportunities exist for us to add additional dental chairs going forward. And then as Hancock opens in FY '27, there is a pretty significant presence of dental capacity that would be added in that location.
Did you
Next
say
slide.
Colony Park also will have facilities there?
I'm sorry?
Did you say the Colony Park will have a dental facility within it?
That is my understanding. Is that correct? I lost Stephanie. I believe
I
so.
believe that's
Manager
correct,
Jones,
yeah.
I'll confirm.
All right.
I'll confirm and get back with you.
Probably is a bullet point that could be included, I think. To your point, Manager Jones, I think there probably is a bullet point that could be included. It'll be FY '26, I imagine, late '26 or early '27 on a fiscal year basis.
Okay, this community need and set of initiatives is around care coordination. Again, care coordination really touches a lot of the other areas that we've already talked about, but it does add, just the way the plan was organized, some specific services that we haven't discussed yet. So in addition to the inpatient transitions of care teams, this area of the health equity plan included our care at home team. So this is individuals that are leaving the hospital or leaving skilled nursing, and they need some bridge care at home while we connect them to primary care, while we connect them to other resources, and potentially, contracted home health that would provide more specialized services. In addition, our virtual care work lives in this part of the plan, as well as the investments that we've made in the patient navigation center. So all of the patient appointing functions, the referral management, the transportation assistance, our patient experience and patient advocacy groups, our nurse triage, all of those navigation center services live in this part of the plan. And then finally, this is also where we captured the plan's intent to embed community health workers across all of our care settings and embedding our community health workers there to help address and support social determinants of health, patient navigation, and care coordination across the system. So we have, as we stood up the direct practice of medicine here at Central Health, the Navigation Center is certainly up and operational and continuing to scale. Those were big upfront investments, and I'd say a large part of the health equity plan was front-loaded in terms of costs for really the first 3 or 4 years. A lot of the back half of the plan, the costs that you see associated with that part of the plan are the continuation of prior year builds. So a lot of the builds are in those first 3 to 4 years. The Care at Home team did launch as part of our skilled nursing and transitions of care work. And we have embedded community health workers within our specialty care clinics, our skilled nursing teams, our transitions of care teams that are in the hospital, and we'll continue to invest in community health workers, including creating opportunities to train individuals from the community to be community health workers in our environment. We're continuing to expand our complex case management. They went through a pretty big transformation over the past year or two, from being a case management team that really accepts patients by referral to one that's really looking at specific patient populations or cohorts of patients, managing those patients more specifically, and then creating a longer-term monitoring arm so that we can help get folks back on track if they need help after receiving more intensive case management. We are continuing to work through our social determinants of health approaches. Our significant investment up to this point has been in transportation. We provide a lot of rides. Community Care provides a lot of transportation. Sendero provides a lot of transportation. And that's an area that we're going to look to align going forward. We're also all spending a lot of time and effort to develop case management functions across all three organizations, and we want to be very deliberate about whether it's Community Care, Central Health, or Sendero, that we've got a coordinated approach to how we're case managing our patients. So that's another part of our work for the upcoming year. As we continue to expand our care at home services, one of the needs or areas of opportunity that we've identified is a opportunity around at-home dialysis that we've talked to you all about in other presentations. For our patients, many of whom to be successful with in-home dialysis, we're going to need to provide some additional supports in order to really maximize that opportunity and also help us address some of the limited chair capacity for dialysis that we have today. Next slide, please.
Could I ask a question?
Yeah.
Yes, ma'am.
On the, just a request on the complex case management and also on the care coordination. I'd like to ask for a briefing with more detail on that at some point in the future. Not too distant future. I'd like to understand how that's working.
Okay.
So if we could get that. And what I'm curious about is the extent to which it's available to our MAP and MAP Basic folks, how they access them. Do we cover everybody? Is it proactive in reaching out? When we enroll them, do we tell them about it? You know, those kinds of things. So I'd like to ask about that.
Sure.
And then on the SDOH, how are we doing on the food insecurity?
And that's its own slide that Monica's going to speak to momentarily.
Okay.
Yes, ma'am. Our next slide here is on, I'm sorry, will you go back one? It should be, yes, eligibility and enrollment. Several things that we've done over the course of the last 18 months or so. In FY24, we expanded, as our teams are working out of the hospital, really expanded virtual enrollment opportunities at the hospitals and then also in some of our community partner organizations. We also created more real-time access for some of those high risk or more complex patient scenarios where real-time eligibility really is needed to help facilitate care for those patients. That's a technology that we plan to continue building on in future years. We also developed walk-in enrollment access here at Cesar Chavez in 2024 for individuals experiencing homelessness. And we've been working very closely with the Sheriff's Department to make sure that we're taking every opportunity we can to help enroll Travis County inmates in the MAP program. MAP or coverage in general really is the key to being able to access care. So we need to do everything we can to help continue to enroll folks in our programs. And I will reiterate that right now we are seeing all-time highs for MAP and MAP Basic enrollment really every month. Since just a few years ago, we've seen a significant increase in our overall MAP population. As of the end of May, we have about 34,000 enrollees in the medical access program every month. MAP Basic that started in 2019 is now almost 58,000 enrollees. And then we've got more specialized program like the MAP Basic Dental Only program for individuals that move into Sendero or age into Medicare. We're able to continue providing dental access through that program, and that's another 6,000 people accessing services through that program on an annual basis. But overall, in the last 10 years, we've seen about a 40% increase in our program enrollment just for MAP.
Can I ask a
quick question?
Yes,
on
sir,
that?
please.
You said you're having an increase. Do you have data on that in terms of demographics, one?
Yes, sir.
And the other question I've asked, and not only for this, but all of them, do we have demographics information on the staffing that we are using to do the community outreach? One of the questions that have come up several times to me is the limited number of African-American staff in the community outreach efforts. And even here at Central Health itself, administration. So I'd like to see if we could, to see if you could provide that information at some point in time.
I think we'll have to go back and put something together for you, Manager Jones. I don't have that to speak to today. So we absolutely report on demographics for our enrollees as part of our demographic report and another, our annual report and other areas. We can certainly resurface that. In terms of outreach, I think we'll want to look at our teams as well as some of the contracted partners that we work with to do outreach and see if we can't bring a full picture back of what that looks like.
But are we really utilizing outreach contractors to do that? Because what I'm hearing is, well, we were at one time, but now we've cut back. And you probably know more where I'm heading. Well, Ted can probably speak.
Ted can probably speak to outreach better than I can.
Yeah,
But
I can just quickly, we actually just completed an RFP process and have hired one new outreach vendor. We're in the process of bringing a few more on as well. I don't want to talk about the ones that are still in process, but the one that is now part of our consultant group is Achi. So they've been on board for probably, how long? 2 months or so. We're in the process of doing a smaller. Sorry.
It's the, Austin
they-
Asian
they don't-
Community Health Initiative.
Yeah.
But you know what I might propose, Manager Jones? Let's follow up with you after the meeting and make sure we understand the information that'll be really interesting and develop a fuller picture for you. It's a really good question. I know it's come up a few times, so let's understand exactly what will be helpful, and then we'll take a stab at it.
Well, I've requested a meeting for us to talk about that as it relates to Central Health Administration offices as well. But yeah, I would appreciate if we get more information.
We actually are scheduling a meeting with you at your request regarding some outreach to black churches in the community. So
Right,
I think that's already on our calendar.
Okay, then. I just want to make sure because there's a feeling that with what's going on nationwide, not only about immigrants, but also within the African-American community, that's an attempt to undermine what's being done. So I want to make sure that's not the case.
Manager Geronimo.
Yeah, I might just add to what Manager Jones was, it's on, it's been on. Sorry, that distracted me for a second. In an effort of sense making, John, that quote about the increase in the number of MAP enrollees was a little bit surprising, only because if you read any of the demographic reports from the city, the county, in this area, there was a trend of poor people leaving our Travis County community and the reduction of poverty, and not because we're celebrating it, it's because we have an affordability crisis on healthcare, housing, and on education. So it's interesting from a sense-making perspective, knowing what the overall capacity of who is the universe that we're trying to serve. Let's say it's 1 million people, and that increase is because we haven't been serving all of them and there's an increase? Or is it because, from a sense-making perspective, is it because those people that have left are now coming back because they need those healthcare services? And I don't know how you all work with the demographic report, because it's huge, but if there's a way to figure out what that context is, because that, from a governance perspective, that would just make a lot of sense making around what's the overall need, how much have we done, this is how much we're increasing. But in the future years, and FY 25, 26, 27, the planning years, I've always expected Travis County, and this is just from like information that just from the community, I've always expected us to have a lower poverty rate, lower number of poor people coming into our community because they just can't afford to live here in Travis County. So it's interesting to hear you say that, but it just adds to what Manager Jones is saying, and adding to his, I think part of his question is, are you hiring the individuals that are reflective, that can meet the needs of or meet people where they are? And usually it's helpful to have people that look like them, but that's a whole, that's in addition to what I was just saying. I hope that's helpful, and I don't expect an answer right now, because it's a lot of, that's a lot of discernment.
And
If I may, to your point, I've always been curious about this. How many of our MAP patients or people that we serve at community care might have started out in Travis County and then they moved out, but they continued their services within the Travis County area? And I know that they need to be reevaluated, et cetera, but if they figure out a way to get a local address or keep the local address, I don't know how that works. But that being said, I know that there's some folks that are doing that because they serviced my own household. They come clean my house, they do my yard, So I know that they're out there.
And I would say a couple of things. So one, any time that we do learn that people are using an address that's not theirs, then that is something that we have a compliance process that we actually look into and we track as part of our kind of fraud, waste, and abuse programs. But in general, to the sense of where the population we serve lives, how we use that in, how we look at that in the demographic report, and then how we use that in our planning for where services are being provided. One of the things that we've seen is there are people who actually can't afford to live outside of Travis County, and so even though some folks have skirted to the edges of the county, others, we've seen people just doubling up in households, even in small households. And so one of the things as we look at the demographic report is we look for people who remain in the county and who remain enrolled at either central health programs or in community care that we're able to track, because of course once they actually leave, then we don't have access to their healthcare information anymore, and so it's been harder for us to track. But we see people moving around kind of the Runberg and St. John's neighborhood, and we'd love to have more kind of follow-up conversations on this. Another thing that we're looking at for fiscal year 2026 is collaborating with community care on an overarching community health needs assessment that also includes more regional information, particularly in the areas that are part of community care's service areas as well, so that we can do as much as we can to track where people are going in the nearby adjacent counties who might be coming in to receive additional services.
And one of our key results that we've committed to for this year is an analysis of the MAP Basic, what it would take to continue to grow MAP Basic access. And I might propose that we use that opportunity to kind of broaden a little bit to say, where are we now? How do we get here, right? So what is that growth? What do we think the total denominator might be, and where we want to go? So a little bit of a deeper slice on that, and we could use, if that's acceptable to the board, that key result could be accomplished by giving us that longitudinal view with a little bit of forward-facing projection. Would that work? Okay, so we'll, yeah.
Just real quickly, people keep using the $150,000 to $200,000. I mean, 200,000 uninsured in Travis County, that amount, and it never seems to change. And that was one of the reasons that I had focused in questions for so long. Okay, what's going on here with MAP Basic? Who are we not reaching? Why aren't we reaching them? And the only thing that you can discern from that is that either they don't know where to go to dig into where people are really living, and that would only be because they don't have staff that comes from those communities or understands them. And that's always been a big criticism of ours, criticism of Central Health, And so when you're looking at that human resource description, you also need to look at the fact is which ones are those, what are the job descriptions of those people? Like the promotoras or the community health workers. Who is actually training them to know whether or not, it's like there are nurses and then there are nurses. There are doctors and then there are doctors. And it still comes, it still comes down to the quality of the training that one received. And so that's a need for the analysis of the demographic information.
And I'll just wrap, because I know we need to move on, but I just want to, there are corridors in eastern, northern, and even out in northwestern part of the county of folks who are doubling up in apartment complexes or others. And they're not necessarily calculated in some of this, and particularly on the eastern side where I have most familiarity. I know of many cases like that. So I think we need to do some groundwork in terms of finding these locations and going into them and investigating. And that's why it's important to have a great nothing wrong with our outreach staff. I have a lot of respect for them. They do great work. But I think we need to add to them, and I think we need to add more diversity in the new ones we hire. That's what I'm saying. I'm proud of the work that the ones who we have, but we're a big community now. We used to be the 10th, now we're the 11th largest population in the state.
Country.
I mean, in the country, yeah, thank you.
Just a few other notes related to eligibility and enrollment. So this year and still going into next year, a lot of joint work with Community Care. We both have eligibility and financial assistance teams, and making sure that we are really aligning processes there and taking advantage of technology opportunities, making sure that all of our staff can enroll in all the community care programs and all the community care staff can enroll in the central health programs, is just a great opportunity for us to be more efficient. We've also established eligibility on site at any place where we are starting clinical services. So that's been kind of a tenet of the Central Health Direct Practice environment, is we have had on-site eligibility available there for really on-the-spot assistance for our patients that may need to renew their coverage, or their coverages may have changed. We have expanded our virtual enrollment services for individuals that are incarcerated. Our teams do some classes for the Travis County Jail on an ongoing basis to help enroll those individuals. A big effort that we'll have starting this year, and again we'll continue into next year, is the translation of all of our MAP program materials and all of our patient-facing materials into languages in addition to English and Spanish. So trying to look at our patient demographics in languages other than English and Spanish, Arabic, Vietnamese. There are several that always seem to rise to the top every year in terms of our patients' languages spoken at home. We are also investing in quite a bit of time and effort into our integration opportunities. This is with the TPA that Manager Valadez mentioned at Sendero, with our electronic health record system, so that we've got real-time access to up-to-date eligibility. We have a lot of patients that, and again, this is to Manager Valadez's point, we have a 6-month enrollment period for the MAP program still. And because of that, we've got to continuously help re-enroll our patients that have ongoing medical needs. So just looking at every opportunity to do that as well. We, with our direct practice, started our financial assistance program. It's very small, but it helps with the situations where someone starts out their care with us as a MAP program patient and they lose their coverage because they move out of the county. This allows us to continue providing services for them on a temporary basis for continuity purposes while we help transition their care to a better environment. In addition to expanding eligibility for individuals experiencing homelessness here, we have a team member that goes to Sunrise Church and helps with MAP eligibility there as well. And then both Community Care and Central Health are continuing to invest in assistance for our patients in our community to enroll in Medicaid and to enroll in ACA products. And I mentioned earlier our continued investments. One of the things that we've seen that we're investing in that continues to get to face funding cuts right now in the environment is that SOAR specialists, the individuals that are helping very complex individuals with disabilities navigate that Social Security process and the Medicaid enrollment process. It is months long, and I think we've heard that we have some of the highest success rates with actually getting people approved for disability and Medicaid, and that's because we can really pair the eligibility process with the clinical process, and we can have physicians and case managers that are bringing the clinical information into that application process, and I think it's been a big factor for our success rate there. Yes, ma'am. The only other one I'll mention is we're continuing to invest in our patient assistance programs, the prescription assistance programs that some of the manufacturers offer to provide drugs at no cost to patients if they qualify. Again, navigating that process is not easy, and we want to get patients access to drugs in a timely fashion as possible. So we have patient assistance program staff that help navigate that process for patients when there are high-cost drugs that are available through those programs. Next slide, please. So in addition to eligibility and enrollment, the Health Equity Plan spoke to coverages. Our coverage programs, our benefits, our underlying structures. Hopefully nobody falls asleep in this part, but this is what I get to have a lot of fun with. So in FY24, we were able to expand the premium assistance program that Central Health offers to enroll individuals into the ACA program to include our MAP Basic individuals up to 150% of the federal poverty level. We expanded, each year it seems we're expanding our CHAP expansion program. This year we took that program at Sendero from around 700 individuals in that high-risk enrollment population to just over 900 individuals. And we are constantly looking at opportunities to pair up the CHAP expansion opportunity with where we have opportunities that patients could benefit from. So just to give a few examples, right now we are doing a lot of work to look at the transplant opportunities, specifically looking at liver, heart, and lung transplants. Right now, if you do not have insurance coverage, you're excluded from the very beginning from accessing transplants. So as we have many patients in our population that could benefit from transplants, and we have partners in the community here with Ascension, with UT, with University Health in San Antonio, that they're doing a lot of the transplants today for Sendero enrollees. We've got a lot of opportunity to develop programs to add access for those services where they've never existed before. We're also looking at certain cancers, and if we can use the CHAP expansion program to open up additional access and treatment opportunities for patients beyond what they have access to today. I mentioned the creation of the financial assistance program. That will continue to evolve as well as we move into the world of Medicare and Medicaid in our practice, and then really trying to connect our patients that are inmates at the Travis County Jail to coverage so that they can receive services from us while they're in the jail if they have a specialty care need, and we can help connect them to services once they discharge. Again, the maintenance of coverage is just key for patients being able to access care. Some of our upcoming opportunities, we're still, Manager Valdez, we are not going to give up on a 12-month MAP enrollment, and we are going to continue to work with Ascension to identify every opportunity there we can. MAP Basic is a 12-month program, and I think that does help to retain patients in coverage. people don't stop having chronic conditions and prescription needs and needs to go to the doctor at 6 months. So we're going to try to continue making that happen. I mentioned the enrollment into third-party payers. Our Medicare enrollment is complete. We've got 1 or 2 outstanding items related to submitting our Medicaid application. And again, our initial approach here is to really align what we are going to contract with and enroll in at Central Health with our patients who are served in the community care environment, where they really accept all Medicaid, Medicare products. But really our initial step into this space are patients that start out with us as MAP or MAP Basic, and then they age into Medicare, or we help them get into the SOAR disability program. So these are still our patients. They're just changing coverage, and we want to be able to continue providing them with services. We'll also, in terms of contracting, really try to target the dual eligible Medicare, Medicaid populations and take an incremental approach to third-party payers so we're not crowding out MAP patients, MAP Basic patients from our environment. I think that's all we'll touch on here. I know we're
I have
very
a
short on
quick
time.
question for
Unless there's
you.
questions, sure.
The financial assistance program,
Yes, ma'am.
not ringing a bell, I may just be not remembering. What is
Yep.
that for?
So that program is, it's the equivalent of the charity care financial assistance at the hospital or the sliding fee scale programs at the FQHC. For us right now, it's probably only a couple of dozen patients. These are people who start out with us as MAP or MAP Basic patients, and then they lose coverage because they move out of
Okay.
county, or they take on a different job and now their income exceeds it, or they enroll in other coverage that we don't accept in our clinic. This allows us a short-term opportunity to continue seeing them and providing the services in our 4 walls while we case manage those patients and help navigate them to another care environment where they can be seen for ongoing treatment.
So it's an interim kind of thing?
It is interim so that we're not abandoning patients as their care or their coverage transitions. Yes, ma'am. It is
Just
not
to-
intended to be a permanent or comprehensive
Okay,
coverage by any means.
just as not to go into now, but
Yes, ma'am.
in our budget presentation where we talk about initiatives that were talked about last year, I'd like to just remind y'all to give me an update on any relationship with Tex Health.
I'm sorry, realize?
With Tex Health.
Tex Health.
You know, Tex Health is Tex Health Central Texas has state-funded premium assistance to help folks get on coverage. And it may be a referral opportunity, it may be another opportunity, but I'd like to know how we're working with them. The other thing is they just received legislative approval to go statewide. Not that, I mean, we're not statewide, but that's just an FYI. So when y'all report back to us, when we're talking about those budget initiatives we mentioned from last year, if you'll just be sure and include that. Okay, thank you.
Thank you. Next slide, please. Pharmacy, another very important area and a significant area of expense in terms of our budget. Really, the health equity plan helps us address this from a strategic approach where we are maximizing the 340B opportunities, the manufacturer donation programs that I mentioned, also mitigating some of our regulatory and financial risk associated with the 340B program. And, there are tens of millions of dollars of benefit that we receive through that 340B access. And both on the manufacturer side as well as from the federal government program side, that program is always evolving. So part of us mitigating risks is bringing more and more of the pharmacy service in-house with community care. And just like Del Valley that just opened, really looking at every opportunity for us to add pharmacy access points within new clinical service locations as we're building those out. There are also opportunities for us to get a lot more efficient. One of the things that we're jointly planning with Community Care Now, that was part of this, this initial planning, was looking at mail order replenishment, looking at courier services, and looking at centralized pharmacy dispensing. So very similar to an HEB model where most of their prescriptions are actually filled in a central facility, and then they're driven to the more community pharmacies. Not all drugs, but a large number of the maintenance medications. So again, looking at drive-through pharmacy, looking at opportunities to build more access points as we add clinical sites in the future. And then the only other area I'll mention here is joint planning with Community Care around infusions. That's efforts that are underway now. Will probably go live as part of our FY26 plans with them to build infusion capabilities both in the FQHC scope environment and in the central health environment, so that depending on which specialty we're talking about, we've got access in addition to what's being provided today through Ascension. And then as Hancock opens, as you all are aware, there is a on-site Class A pharmacy as part of that operation, and another drive-through pharmacy plan for the Colony Park location. Next slide. Surgical and procedural access. So a lot of overlap here with the hospital services, the specialty care services that we mentioned earlier, but to call out a few additional initiatives that were part of the health equity plan. One of the services that we stood up here at Central Health in our direct practice in FY24 was a pre-surgery clearance clinic and a medical optimization clinic. Oftentimes our patients cannot go under anesthesia if their underlying medical conditions are not under control. So as we're standing up more and more procedural capacity, GI, surgeries, things of that nature, we need to make sure that we can actually get our patients in the door to have that surgery. We did launch our general surgery services, and now have 2 general surgeons that are providing direct care in the central health environment, and a number of gastroenterologists, including co-hires with University of Texas, providing GI and ASC-based endoscopy for our patients. ENT is a work in progress for us, and we're working to mitigate a few issues in that area, but hope to still bring on expanded ENT access here before the end of this fiscal year. I already spoke about the women's health, sexual and reproductive health procedures, vasectomies that we've added. And then each of these direct services that we're offering in the surgical space do come with additional contracted expense in our surgery centers and in our anesthesia contracts. So you'll see that reflected in the numbers there as well. Dr. Martin.
Kind of related to surgery. I see a lot about tool ligations. You mentioned vasectomies. Vasectomies, of course, are a lot cheaper. Are our primary care doctors going to be doing those at our clinics, or just that's urology?
We need to, well, this goes back quite a bit. I think primary care docs used to, and then they lost access to education. They now potentially have new access to educate, and we offered it, and we didn't have any takers. So we now have a new opportunity, and haven't reapproached it, to be honest. But
just a big cost saver. I mean, a ligation is
in clinic
5
procedure,
figures,
yeah,
you know, so
100%. And the residency, I think the family medicine residency is an opportunity, and that's where we had originally offered, and I think we go back there.
Okay, thank you.
Right now it's through a private urology group and through UT providing the vasectomies for us, but we really try to make every form of contraception available to our patients and sterilization options. We also provide a significant number of the IUDs and LARCs in our different environments.
Are IUDs covered under, they are now?
Yep.
Because that's
IUDs and LARCs are covered, and they're also 340B discounts
And are
in
the
our
primary care
FQHC
doctors
environments.
inserting those?
They are.
Okay, good. Thank
Next slide. Oh. Sorry?
Does that apply to age? In other words, does that cut off at any certain age? Or is that, yes, yes.
We can follow up with you offline, Manager Jones.
So this goes to the, this is where we're going to talk about the food insecurity work that we've been doing. So when we started in fiscal year 2024, we, in addition to reaching out through the community conversations and reaching out to board members for emerging priorities, we also started an internal work group across all of the departments in Central Health, working and at Community Care, working in social determinants of health to try to determine what the direct providers and people working in the field thought was the #1 social determinant of health for us to suggest addressing in fiscal year 25. So we started that work in 2024, and also this aligned with proposal from Chair Kitchen and Manager Motwani around food insecurity that became a budget resolution strategic priority. We took that strategic priority and launched our second iteration of the community, the Central Health Community Healthcare Initiatives Fund, and built it around addressing food insecurity. So we worked with the clinical teams, the community health workers, and kind of the frontline staff. We worked with Stephanie's teams to develop a scope of work in a request for proposals, and went out to the community around food pharmacies and kind of food pantry services based on where it was determined that there was the highest level of need, highest level of food insecurity in our patient population. And we also went out for providers of medically tailored meals around 5 different conditions. And then we also went out for RFP around workforce development of developing healthy meals for people experiencing homelessness, by people experiencing homelessness in some of the shelter settings. We have been very successful with one area, and that is we executed our contract with the Central Texas Food Bank, and we had our first event around the food pharmacy, around the food pantries on Friday, June 6th, last Friday. And we will have mobile food pantries regularly at Community Care North Central, at the Pflugerville Community Care location, at Southeast Health and Wellness Center, and at Hornsby Bend. We are negotiating a contract, so we've selected a preferred vendor for the medically tailored meals, and we're in the process of actually negotiating that contract, and also going out for bids on quality control around kind of doing assessments of the medically tailored meals program. So that should be coming online shortly. And then we also didn't have any providers submit. There were providers that were interested in submitting for the workforce and the meals for people experiencing homelessness, and they just didn't meet the deadline. So we're going back out. We'll be reissuing an RFP that we expect people to actually have submissions for in the near future. We also, in this focus on food insecurity, the Central Health Equity Policy Council, which is a group that works with organizations all across the community to address, you remember the last, they presented, I guess, a couple of meetings ago on the impact of the opt-out HIV screening policy and the good success they had. So the Health Equity Policy Council kind of is a collective impact model convened by Central Health, where the policy council members choose from a researched menu of options on what they would like to work on in the policy arena. And in 2025, the initiative is Food is Medicine, and the strategic planning for what policy initiative around food is medicine that they're going to address will kicked off on Friday, May 30th. And they also helped set up a learning event around food is medicine at Southeast Health and Wellness Center on May 22nd. And where these community health initiatives funds programs are pilot programs that are stood up for they're intended to be implemented over a 2-year period, and then depending on the outcomes of the programs, then they can become part of our ongoing operations after the end of the 2-year program, if we learn from the initiatives and if they're successful.
I have a question.
All right.
Madam Chair. I'm surprised that nobody submitted any proposals, especially since we're living in a chef and restaurant entertainment world in Travis County and Austin. So are we reaching out to those organizations, the restaurateurs and the chefs and the independent kitchens where people can go in and do their health, they get their health certification. They're not a stand-up, but they're actually, I know some that are along Burleson Road.
The ghost kitchens?
Yeah, all kinds, yeah. And so I want to make sure that you're reaching out and sending notices to those entities, especially the farm to table.
Oh, the farm to
all
table.
Those, yeah, all those entities, because I just can't believe that nobody submitted. So if we can do that, thank you.
No, thank you. We'll share that with Belina and procurement. Thank you.
Are you familiar with Equidad?
Yes.
Okay, they're providing that type of service, I believe, in Northeast Austin and Northeast Austin. Are they, I don't know if they've put a bid in to work with or to be part of this or not, but I would encourage that we look at that model, particularly in other areas as well. And perhaps they may apply, may outreach to us as well. I'll mention it to them. But I think that would be a good organization to do something like that.
Thank you. We can publicize the RFP when it goes out, absolutely, with Equidad. Yeah, thank you. And with the ghost kitchens, and yes, absolutely. And then also we're still continuing, this is our additional focus for 2025 and 2026, but we are still continuing our work around transportation and rideshare. And so far in fiscal year 2025, we don't want you guys to miss the outcome metric. So far just on the Central Health side, we've provided over 11,000 transportation rides for services, I think through the end of April of 2025. So that's not even a year to date, but that's through the end of April.
Yeah, just part of the evolution of transportation. So we use a lot of different transportation resources today. We've got taxi cab vouchers, bus passes. Our rideshare program is significant, as well as wheelchair accessible transportation and even ambulance transport where that's needed. All of those solutions, I think, do in some of our environments fall short. And one of the things that our team is looking at is an opportunity to provide some full-time employment opportunities for transportation that we provide directly. We have a lot of challenges with rideshare, either showing up at all or waiting for a patient, and that becomes a missed care opportunity for patients. So particularly in some of our higher risk environments like the skilled nursing facilities or in respite, trying to have a small amount of dedicated in-house transportation access so that we can ensure that patients are getting where they need to go is one of the areas that the team's looking at for 26.
Are you looking at Waymo?
Waymo scares me to death, but I'm sure someone is, sir. Yeah. Next slide, please. All right, so we actually started with some of this with Jeff, so I'm going to hit this very quickly in terms of the health systems, the interoperability and technology investments, and data and analytics. So as we've discussed, this includes the migration to cloud-based services instead of on-site services. That provides us with a lot more capacity and scalability of those resources, and also the redundancy if there's a major system outage. Almost all of those services are set up with intentional redundancies. Investments in data governance and integration. This is with our EHR. This is the HMIS system I mentioned earlier, and really making sure that data is getting to the right places. A emerging effort with the University of Texas and APH and Integral Care, Community Care, Sendero, all at the table with Watershed, and how we can create more accessible data at the point of care. This is our development of our EHR. That is an ongoing, constant effort, and the many integrations to medical equipment and other clinical partners in the community. We have invested in a number of tools around data and system security. As you see on the left-hand side of this slide, just an example of the security platform filtering over 2 billion potential threats down to an actionable 34 in real time, so that our joint tech team can respond to those real threats very, very quickly. The cybersecurity threat continues to grow and get more sophisticated, and because of that, to Jeff's earlier point, I don't think our investment in this space will ever go away. We're going to have to continue to implement solutions to maintain the stability and security of our systems. We have had lots of partners and lots of examples, both in town and around the country, that systems go down entirely because of cyber attacks. So our team is really doing a lot of work there to protect us from that as best they can. Next slide, please.
Just a quick,
Just a minute.
when, I know that we're in the process of searching for a compliance officer. When that's done and when the board appoints the compliance officer, I think it would be important to report to the board on our process for addressing risk related to data security. So if we could just make sure we put that on the
Understood. And
agenda
we
at some
actually have
point.
a
I know our,
security officer as well. John Clark,
Right.
as our CIO, is also our chief information security officer. So it would probably be a collaborative approach to that.
Yeah, and our
So
privacy
we can answer questions on that if needed in the interim.
well, just at the appropriate time, it'd be, I think the board has a responsibility there, so reporting to the board would be important. Thank you.
I think this is our
Yeah.
last.
Oh,
I'm
just
sorry,
okay.
Manager Johnson.
Excuse me, in light of what's going on at the federal level, I also think we need to look at, to the degree that we can, what controls we can, or limitations or safeguards, thank you, that we can put to try to limit what has happened, particularly given our unique population and what we're seeing happen from our own federal government. So I think we should at least go on record as saying we're concerned about that.
Yes, sir. This is the last of our initiative slides before we move to the key performance indicators that Monica mentioned earlier. Most of these should seem very familiar. In fiscal year 24, significant infrastructure investments coming to fruition with the East Clinic that opened and the Capitol Plaza Clinic that opened. Again, we didn't want to delay bringing services online while we completed the larger Rosewood Zaragoza Clinic project. So we've had a rolling implementation of those clinical services. The Hornsby Bend Clinic opening, as well as the major capital investment with the third-party administrator services at Sendero, all in FY25, or excuse me, in '24. Progress in FY25 so far, a lot of work going on at the Clinical Education Center as we're starting to go live with respite and clinical services, as well as some of our administrative functions that have moved over there this year, our HR and training teams, our EPIC team that's doing training for our staff as they come on board. The very recent Del Valley Clinic opening, and then building out a couple of other capabilities here over the past year, our revenue cycle processes that help support the Medicare and Medicaid rollout, as well as continued investments in EPIC training for all of our clinical team members as they come on board. Going into FY26, completing the Hancock construction, and we'll have a phased implementation of services into that Hancock facility, starting with the relocation of the David Powell Clinic, the relocation of the convenient care services at Community Care, and the pharmacy and the lab, followed by FY27 implementation of the specialty care services, some of the imaging services and dental services in that kind of second phase in FY27. Monica mentioned earlier, we're also completing or starting a community health needs assessment jointly with Community Care and with Sendero as really a full system view of that community health needs assessment. We're looking at our resources associated with that, both in-house and contracted, for actuarial and analytics capabilities for modeling some of that out. We have a lot of medical equipment throughout the organization, throughout the system here and at Community Care, and making sure that we've got a robust system for the maintenance, the testing, the calibration of that equipment on an ongoing basis so that we can stay out of trouble with Joint Commission as well. And then, as I mentioned, a lot more efforts around transportation and some of the fleet management that goes with that, both for our existing vehicles and vehicles that we would use to actually transport patients in the future. We are at or potentially beyond capacity today for instrument sterilization. That's another area that we've partnered with Community Care up to this point. We're going to add some instrument sterilization capability related to Central Health surgical specialties, where we shouldn't be transporting some of the delicate and expensive instruments for some of those specialties, but also working with Community Care to plan for some centralized instrument sterilization so we don't have that spread out across multiple areas. We've really got one center. But right now that's at Southeast Health and Wellness. It's in a back hallway and is both at capacity and that's in a facility that really was not intended for that purpose. So we have some humidity and temperature control issues that we want to try to mitigate there. And then continuing the planning with Community Care around the Runberg, North Austin expansion. The South Austin Clinic is a significant challenge. Right now, Community Care is having to look at contingency plans associated with not being able to keep that, not be able to keep the temperature at a reasonable level for patient services. So that site is very problematic, and we've got to make some investments to preserve access in that area of the county. And then Colony Park, certainly still on the map as well. The design, I think, is nearing completion and construction starting. So excited for that project to come online as well. I think we'll happy to answer questions before we turn it over to Sarita for discussion of the key performance indicators.
Yes, Manager.
I just have a brief question, and John or Dr. Lee, I know you've mentioned this before, but where would the centralized planning for facilities be? Is that an FY25 or 26 issue? This is, I'm thinking of facilities, not just this plan, but just enterprise-wide.
questions. We have a key result for 25 to ambitiously try to provide a 5-year outlook to some of the facility planning. I think that is a sort of concurrent conversation with some of the system integration and future state conversations we're having with the board. So we'll narrow the confidence intervals as we get deeper into it. But my hope is that by 26, we have a much clearer window and a more strategic 5 to 10 year outlook, so we know what we're aiming for. But we're moving our way in that direction. Thank you. Yep.
I don't have a question. I just want to thank you all for this report. It's very comprehensive. It's clearly, I can clearly understand it and read it, so thank you for all the effort.
Question? Oh, you go first.
No, I'd like to concur with my colleague, but I also would like to encourage us, to the degree we can, use this as discussion with commissioners' courts, and not only at the court, but also maybe once a year, meet with the community organizations and other, and say, by precincts, and let them know, because this is a lot of work. And we shouldn't assume that the public doesn't care, but they don't know. And I think the opportunity we can make available, I would encourage us to consider doing that.
A couple of things. The fiscal year 26 planning, I'm assuming that this is the area we should be thinking about for our next budget, and that this is what you all will be connecting the dots between this and the PKRs and other things that we're still finalizing. So this all still comes together. But can I read this as what you guys are thinking of is our next step for 26, all subject to what we do with our budget?
I think it's a large portion of it,
Well, for the health equity plan.
just the health equity
Right,
plan,
right, right.
specific items, yes, ma'am.
Right, so, so I just want to mention that, the fiscal year 26 planning depends on what we fund. So we'll have to be thinking about that as well as the other initiatives in the context of our budget.
Yes.
Okay, and then,
And Chair Kitchen, could I build on that? It's such an important call out, and it brings us back to the point you made partway through, sort of lifting us up, like why are we doing this deep
Yeah.
dive? What do we plan to do? What do we budget for the given years? What have we accomplished, and what might be next?
yeah,
And part of what we'll have to tease out together as we do that strategic planning is when we say sort of stabilize and don't go backward, there's something nuanced between like, hey, just slam on the brakes and don't make any forward progress versus this is the sort of very natural arc of what we've been building toward for several years. Land these planes safely, right? And so there's a little bit, I think, in that column that's more toward that latter. It is already a fairly parsimonious list. And this run through has given us the way to see the logical flight path, if you will, in one set of slices. There's different ways to see it. So the broad direction we received from the board is that is one major body of the budget is let's not go backward, right, on the healthcare equity plan. And the second major body you reference is the FY26 kind of must-dos, of which we're going to come back in June and take a second run at it. But the first run, right when the hail took out the power, was that we heard that the year of access, that made sense to folks. The other parts, we're going to come back and have a follow-up conversation.
but
yeah.
we have to look at it all together.
Yes.
So, which I think is what you're saying. So when we look at it all together, we have to see what we can decide that we can afford.
That's right.
Based on and what we want to do about our revenue. So,
right.
no, we haven't said that this health equity plan list of fiscal year 26 outweighs any new initiatives or outweighs other things. It's just we're getting information about each of the pieces. When you guys bring it all together, then we'll see where we're at from
Yes,
a
ma'am,
financial
that's right.
perspective.
That's exactly right.
All of these things look great, and they are the next, it's definitely an arc of improvement. It's just that, we'll just have to see where we're at in terms of dollars also in the context of the other things that we're talking about, and in connection to performance tracking. So I'm really interested, when we talk to the community, I think it's important that we talk to them, you know, about these initiatives, but we also need to talk about performance. So I guess that's our next thing. And just for everyone, I think this is great going through this level of detail. We have about 30 more minutes after we finish this that we're gonna need to spend on the Board of Managers meeting. So just FYI.
We're ahead of our 8:15 p.m. goal, so.
What?
We're ahead of our 8:15 p.m. goal, we're doing great. We're under promise and over deliver.
Okay.
Yeah.
I don't wanna rush this. I'm just reminding everybody you don't get to leave right after this, so. No, they didn't set it up.
Good afternoon, managers and everyone. I'm here today to present an update on the Healthcare Equity Plan KPIs that were previously shared about a year ago. Can we go to that first? This first table is basically a reminder of high-level categories of those metrics that were selected with a brief description of each. And let's go to the next slide. This next slide is an actual, shows the actual measures that we plan to review along with their statuses. You'll note that accurately capturing lead time to new or established patient appointment is a work in progress as we're diving more into our EPIC patient access modules and understanding the nuances of those data, because this is important information. We want to make sure that we're reporting it accurately, and as we dive in and we find aberrations in the data due to changes in processes or workflows, we have to make sure that we're accounting for that. And we're also working to refine our care coordination measure of admission to hospital or SNF discharge, making sure to remove planned admissions for services such as infusions, chemotherapy, post-op admissions, and as well as removing patients who expired while they were in the SNF. Next slide, please. This first chart represents the total encounters for Central Health patients in the direct practice space. And it compares FY24 volumes to FY25 volumes as of May of 2025. So just a little quarter shy of complete fiscal year. The start services represent service lines that started seeing patients in fiscal year 25. And you'll note that in 25, all of the service lines exceeded or are on track to exceed the FY24 volumes. This next slide represents work that's done in our care coordination spaces, our respite, our SNF and respite spaces. So these show the total number of bed days for members spent in SNF, the upper chart, and in respite, the lower chart. If you're comparing these charts to the ones that were previously shown to you in 24, you'll note that the original calculation that was used had a total for SNF for the approved number of bed days, which we realized isn't really the right way to look at this. That we really should be looking at how long the patient was staying in the SNF. And then we'll note that there is a decline in the total number of respite bed days in the first 2 quarters of FY25, which really reflects a decrease in the number of respite beds that were available at the marshalling yard.
So, can I I'm sorry, so these are the KPIs that we are at this point in time using to measure performance, right?
Right.
Okay, so then on,
Specifically related to the health equity plan.
yeah, related to the health equity plan. So on the medical respite, this is total bed days, right? It's not giving us the average per patient or even the number of patients, right?
And we do have those numbers, but these are the metrics that I believe that we agreed on, that we would be reporting to y'all.
Did we vote on those metrics?
Can we get those?
Yeah.
I don't remember, this was what was presented in April of
Yeah.
'24, but I can't remember if it was.
Yeah, if we voted or not. The reason I'm asking is because, I mean, this is great. Y'all are doing what we had talked about. I'm not saying that you aren't.
Sure.
I'm just saying that I think it would be more useful if we could understand what's the, sort of the average stay per
Yes.
patient,
We have
and
that.
even more important is, I'd like to know how many people we're serving. So is that a refinement that we could make
We
to
can,
this?
it's an addition.
Pardon?
It's an addition, we can add it.
You could add it? Okay, thank you very much. Okay.
If I may interject, I would agree that this is a better way to look at it. It's important, but, you know, if you have two incredibly sick people that are there for 6 months, it just, what we're trying to do, I think, is what we're doing for service total. And I think the measurement of total number of bed days is perhaps, for me, a better metric. I understand the number is an absolute issue, but I think if the purpose is to provide the care, then it would skew it. If we have 300 patients that are there for 4 days, but they're not that sick, versus some people who really truly need the care, it would seem to alter things a little bit.
I'm
We can
not saying,
provide both.
I'm not suggesting
Thank you.
instead of, because I get your point. I just mean, particularly in the homeless area, it's really important to understand how many people we're reaching. So it's in addition to, I mean, this is great for telling us our total level of service. That's great. But the other thing it also tells us is, particularly with a model where we're trying to make sure we're not discharging folks until we've got a home for them. So we're not discharging them back to the street. It'll just give us more information. Okay.
And we can absolutely do that, and we do have both. And I think to Chair Kitchen, to your point, you know, when we started respite, the average number of days was 37 because we were discharging them on purpose as quickly
Right.
as we could to get the next patient in.
Right.
And now we're trying to hold on to our patients in order
Right.
to connect them to social services. For SNF, the average is 20 days that we keep somebody in that environment. We have that information, and as we get more beds online, so we actually hope to increase some of those respite days. So we can provide both pieces of information.
Yeah, just helpful. I'm more concerned about it's telling me more about the medical respite. The SNF, I'm just more interested in the total volume. But if you could break that down for us in addition to this for the homeless, that would be helpful. Okay.
Just a quick question to that, like, do you all, and I know you, thank you for the presentation. Does Guidehouse give you benchmarks at all around these? I know there's obviously you're meeting people where they need to be and you're providing them those services, but is there benchmarks to this, or are we just trying to figure the services that we're providing?
There are usually benchmarks out there, but when we're doing things a little better, and when we understand that some of those benchmarks might be set relative to inadequate care, we have to reconsider. But yes, there are SNF benchmarks out there that we can understand that
Yep.
what the average length of stay is for a SNF patient, but what does that mean in terms of the
Yeah.
quality of care?
And just to clarify, I wasn't asking about benchmarks for accountability, more for transparency, and
Of course.
if those are based on that and we exceed them, it just makes it's helpful to me just to make sense of the data and whether or not we're doing better than that. That actually means we're serving patients, and if you later show the health outcomes are improving, that actually even shows it even more. But just to Yes, sir.
We do have some of those benchmarks and some of the factors that will actually affect it, and I'll use respite as an example again. The average amount of time used to be, or for SOAR, to complete a SOAR application, to sign individuals up to housing, for housing used to be 46 months. Now with some of the federal changes that have that our nation has undergone, there are not as many people that are working the system. So those benchmarks are now up to 7 months. And so it's changing, so I think we may have to put some of the qualifiers in there.
And another, if I may add, another qualification is sort of the severity of the illness of our patients. And that is skewed. We can't compare ourselves to a rich person from Westlake Hills who needs 2 weeks of respite care. These are incredibly complicated, sick patients that have really poor homes to go home to, if at all. So that's all. I think just for comparison. So
One thing, I am wondering, at some point, will we be thinking about setting our own targets? And as opposed to comparing to people that we wouldn't, that's not apples to apples. But is that the thinking, is that at some point we'll get,
Yes, absolutely.
do we have a thought about when that might be at this point?
I think in areas we are already studying some of those targets, and I think
Okay.
in the coming year we are proposing to set some of those targets.
Okay.
Broadly speaking, I think what I hear and what I agree with is that we want to understand what these metrics mean.
Right.
Not only the trend over time,
Right.
but what do they reflect in terms of how we're doing relative to others, how we're doing relative to our own intentions, what's causing the variation. And that is broadly the intent, to evolve to a place where we can understand where we are and why, and which variation is noise and which variation is signal, which variation is externally caused and which one we caused because we improved deliberately. We're not there yet, but we are actively having these conversations. Takes a little time to bring all that into focus, but I think we're making a lot of progress. Even in the last 18 months, I'd say we're making a fair amount of progress. We have more work to do, but that is absolutely the intent.
And we do
What I
look
would
at
like-
a lot.
go ahead.
I was just gonna say, we do look at a lot of those deeper metrics in our different service line meetings that we have with the teams. So we have specific metrics for each specialty that we're starting to look at, as well as some of these other environments. So I think if we can understand what's important to the board, we can bring those back in whatever the venue is, whether it's strategic planning or the medical committee. We can bring back some of the quality and operational metrics for different service lines. One of the things we talked about with Dr. Martin and Dr. Brinson yesterday was using the medical committee to potentially do a deeper dive into a specific service area and talk about the model, talk about the protocols and the way that we're approaching that service, and we could bring the metrics associated with that particular service to that venue as an option.
if I may, I'm
Sure.
sorry. I think that it's asking staff a lot to do, there's so many variables. If then employment goes through the roof, if interest rates go through the roof, I mean, what will happen to housing? The number unhoused will be enormous. And so those are, I think, it's a difficult thing for, I think, to ask the staff to manage versus, I think, saying, let's kind of see how many people we get to where we want them to be healthy and housed. And I know that's kind of vague, but there's just so many metrics that are so variable and that are beyond our control, that I don't know how much responsibility we can take for that.
Yeah, I'm not talking about targets for the homeless population. I'm now, because I get what you're saying, I'm now stepping back and looking at the bigger picture of this set of data for us. And because what we're talking about is how do we understand performance of our health equity plan. So, so we've got a set of metrics that you guys are sharing with us that you've been working on. I'd like to understand when y'all are ready, give us a timeline. Tell us, is it next year, is it the year after? Just tell us when you will be, I'll use the word targets. You may decide, particularly in conversations with, Dr. Martin, Dr. Brinson, that some of these things are not targets per se, but help us, as a board, we need to understand our progress. We need to understand our performance, and we need to understand what it is we're using to measure that.
Yes.
So, and that's not, that takes a while.
Yeah.
So I'm just asking, let us know.
Okay. My
yeah.
intent, if the board is in agreement, is that the FY26 key results should
Okay.
get closer to what we're talking about.
Okay.
You know, what's most important for access? What's most
Okay.
important for quality? What's most important for people? What's most important for stewardship? You know, how do we demonstrate value to the community, right? So these are some of the high-level metrics. You could imagine us over time evolving to 6, 8, at most 10 high-level
Yeah.
balanced scorecard metrics at a system level that of course are supported by lots of drill down metrics, but at the board level, we should get to the place where we have a more stable set. You know, and I've done this before, we're on a single page. You can see 9 to 12, right? 12 to 24 month look back with control chart, you know, boundaries where appropriate, so you can see which variation is noise and what's significant, and a brief little narrative to describe what we're seeing. And on a single page, you can see the system performance. We're not there yet, but I've done that before, and we're evolving in that direction, and we'll need guidance from the board as to what the windows are that are most relevant. But broadly speaking, those areas I mentioned are likely relevant, and we'll have to figure out which window we want to see.
That's great, and I think the medical committee and can help us, you know, for some of those areas to really help us drill down on what's important to understand, and working with you guys on that. So that's not to take away from what you've done. This is very, very helpful to see now. I just like to keep the big picture in mind.
And it's evolving as well, and, you know, with some of the work that we're doing, that our IT team are doing in that space, will help evolve that analytics to the next, to get to some of those answers that you're, for the questions that you're asking. Right now, the data infrastructure requires a lot of development by that analyst team. So it will evolve and get better over time, as Dr. Lee indicated. Next slide, please. Any more questions about this slide? Okay, great. So this slide represents the number of episodes that were in the case management and transitions of care space. And of course, you'll note that precipitous decline from Q2 of FY24 to Q3 and then Q4. And that decline really, it's not doesn't represent a declination in services. It represents someone not following processes, and the fact that we lost a staff member. So we lost a transitions of care emergency room advocate, and you know that required onboarding, and then the other thing that was at play here is that person wasn't necessarily closing out their episodes. So if an episode occurs in both Q1 and Q2, it'll be counted in each, and that decrease in Q4 is that result of the final cleanup that happened to close out those episodes that were left open. So going forward, I would recommend that we look at Q4 of 24 as our baseline for this work as we look towards improvement. Any questions about this chart? This is our vacancy rate, and this is a point in time metric that the numerator is open positions and the denominator is the active number of employees plus those hired and starting within the next 30 days. And you see that vacancy rate is decreasing over time.
Sorry, is this compared to open positions or budgeted positions by FTE, or how is this calculated?
It's posted positions.
Posted positions, so it's not budgeted positions.
That's correct.
Posted as in
Vacancies. Yeah, as
I'm trying to make a distinction, like, your denominator is the budgeted FTEs, or is it the open positions?
It's the posted open positions that are posted to be filled.
So it doesn't have to be, so it's not budgeted positions?
No, it's not budgeted, total budgeted.
Got
It's
it.
currently open.
Got it.
I
Are we
wanna
doing
take
any
it further.
qualifications for
Is
that?
there a reason why you're choosing that versus budgeted positions?
Yes, it's because sometimes there are positions in the budget that are budgeted to be posted in Q4, but you don't want to be tracked on, if you hadn't planned,
get
a clinic doesn't open
It's just
until
sitting there.
Q4.
Okay.
And so you're not going to have posted those positions, and so you don't want it to be.
Yeah.
And from a board perspective, I'm not thinking every quarter, I'm just thinking at the end of the year, what was your vacancy rate based on budgeted FTE positions? So that to me makes sure that we're being held accountable as a board on the transparency of that budget that we did, and also helps the administration see kind of how we're seeing that as well, and you all will have notes or reasons as to why, which is fair and fine. It's just trying to make sure we're comparing apples to apples. We approved the budget, and then it ended here, and the vacancy rate may be based on your posted positions, but if you do a vacancy rate at the end of like what your budgeted positions, then we can see what apples to apples, if that makes sense.
Makes a lot of sense. I think both questions are really interesting and important, right?
Yeah.
This view lets us know when we want to hire, are we able to hire, what's our sort of balance of flow, retention and hiring. But your question's a very good one, like how good is our planning process? And can we execute to plan? And of course, things change, but can we say, look, the world changed in this very important way. We couldn't have known that was going to happen. That explains this. So I think both questions are very relevant. And I think at a very early stab at this, you may have remembered that in the most recent version of the financial statements, there is one view that now has many expanded columns. And I believe that view, correct me if I'm wrong here, but I think that view shows us sort of current versus budgeted FTE count. And so it gives us a little beginning of that view. It's not a head count, but FTE count, but it's in that direction. I think you're right. Both views really matter.
If I may continue on that note, because I think it's not just irrelevant, but it's an important detail. When we're approving the budget, we're approving it, with so many FTs, for personnel. We may not have that number, but you're giving us a number of how much money's gonna go into personnel cost. And then from year to year, we've talked about having it break down so that the following year, when we're approving another budget, we can do a compare and contrast from the previous year to that year. But if we know that we approved in, fiscal year 24, X number of FTEs, and it cost us this amount, and then as we're moving forward in 25, what the plan is in terms of hiring, whatever your plans are to hire more, whatever that cost is. But it really gives us that more definitive information that, truth be told, that's what your commissioner's court is looking for, because that's the way they read budgets. And that's the way city read budgets. That's how I read budgets. So, just to give you a heads up on that, I think that's becomes more relevant. Just FYI.
Yeah, the city and county don't roll things forward either, unless they identify it as rolled forward. So,
Well, I guess that would depend on whether or not the initiative was approved in the budget resolution. So that would be your qualifier, okay, with respect to the fulfillment of the FTEs.
And I'll just remind the board that the exercise here was to develop a very high-level 10 to 12 metric dashboard to know how we were doing on execution just of the plan. So this is not representative of the entire budget. And our HR team does bring back a lot of detail on all of our employee demographics, our employee turnover. We look at it by different types of roles in the organization. So this is, the challenge here was selecting what is the one metric that we want to add here that helps us. And to Dr. Lee's point, it was, this plan involved adding hundreds of positions. Healthcare delivery is very personnel heavy. And so our ability to hire as we were rolling this out, because it was pretty ambitious, the growth in personnel in the organization over a very short period of time. So I think the board selected this metric because of what Dr. Lee mentioned, that, as we open those positions as intended in the plan, can we fill it? And if not, we may need to make adjustments to the plan, but up to this point, we've been fairly successful. There are only a couple of areas that we've not been able to hire on schedule, so we're pretty pleased with that.
And to remind us, much earlier in the presentation, slide 11, you can see that growth in FTE count from about 280 to about 620. And so if you juxtapose that graph with this vacancy rate, it actually represents just a tremendous amount of talent acquisition and retention to more than double, maybe 240% increase in the head count, maintaining a declining vacancy rate. So
that was also one of the major risks that was identified with the execution of the plan at the time, was just our ability to find the talent to do it.
Well, thank you. Really, thank you for that explanation and reminding us again, this is as it pertains to the health equity plan.
Lots of other metrics we can
Yes.
and will bring back.
Next slide, please. I'll let John speak to this one.
Oh, I didn't know I was speaking to
I'm
this.
sorry, I can if you
Oh,
want.
please, no, go ahead.
Okay, so this represents actual dollars spent on purchased and direct health services. And you'll see the chart actually lines up the quarters in consecutive years, so that you can see a year-over-year representation that isn't affected by seasonality. And any questions there, you'll see that, a lot of the increases are happening in our primary care space, and our contracted specialty space, as well as our behavioral health space.
I just have a quick one, just to review. On Q4 2024, that 14 million in the green one, is that a pharmacy cost or a post-acute cost? I'm sorry, my eyes are not.
It's pharmacy.
Pharmacy?
Uh-huh.
So you spent $14 million, or you spent $14 million in Q4 2024? Is that what?
And that does not include the CARES cost, right?
Well, it would include what we reimburse for MAP and MAP basic patients that are seen at community care. That drug ingredient cost and the fill fees associated with that should be in that number. If it's a Medicare, Medicaid patient, we're not paying for that drug, so that would not be there. I think it's also representative of pharmacy staff that are doing that work.
And it's cumulative year-to-date, so one of the reasons it's so large by the time you get to Q4 2024 is that's the whole year of fiscal year 2024.
The 11 does not add to the 14.
So
Right.
it's both cost and the pharmaceuticals labor and the pharmaceuticals themselves.
Wait, but these are cumulative numbers, so that Q2 is always bigger than Q1 and Q3 is.
Yes.
Huh.
And with
So that's
respect-
interesting. I would have thought actually if we could see just the quarter in itself,
Right.
that would,
Not cumulative.
right? Is it possible to slice so that you just see the quarter? Yeah. Sorry, team. I apologize. I'm guilty.
Once you do that, you're gonna ask for the
Yeah,
total.
Give me more work to do. My question is with respect to the number of patients. With respect to the numbers of patients, that this is, this amount of dollars, like with community care, number of patients for a cost, this is gonna ultimately result in a cost per care, for care. And that's what I'm looking for. I don't know if that makes any sense to anybody, but that's, when you're talking about comparing, so.
It makes a lot of sense. That's not what this was intended to answer, but perfectly valid question, yes, ma'am.
You have questions?
Moving right along.
Next slide.
Okay.
No more questions.
And now we're transitioning to our quality outcome measures, and this measure represents a percentage of patients 18 to 75 with diabetes who had a visit during the measurement period, whose recent hemoglobin A1C was greater than 9%, and again, representing diabetes out of control. And you'll see here that, keeping in mind that the scale of the axis is, it's pretty truncated, so those variations look a lot larger than they are. But you'll note that there is an overall decrease from Q2 of 23 to Q2 of 25. And you'll also note that there's seasonality at play here as well, right? It looks like every second quarter, there seems to be an uptick relative to the previous quarter. And that can be due to several factors. It could be due to outreach efforts or patient education efforts, and how they're timed, right? If they're timed to ensure that by Q4 we have that decrease in that score, then that might be something that's play. With A1C, understanding that it's essentially reflects glucose measures in a 90-day period. And if we're looking at Q2, you think about 3 months prior to Q2, it falls into your quarter one of the fiscal year, which is October, November, December. So whether patients are able to get their medications refilled, or if they're traveling, if they're maybe celebrating a little more than usual with sweets, etc. All of that can contribute to why we might see those higher rates in Q2.
I see that as a little bit differently, in that our insurance plans are calendar year
Yes.
based, not fiscal year based. So their plan is getting renewed in Q1. They might finally get into the doctor, get their
Yes.
meds, blah, 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 and that could be why the
Absolutely.
Q2,
That's
as
absolutely
opposed to something else.
Yes. So, and it could be that they lose care, that coverage as well in Q1.
Just an off question. Are we giving any GLP-1s?
I'm sorry?
Yeah, that's on our pharmacy. It's great.
Next slide, please.
You put it in the water. You put it in the water.
And so this chart shows a breakout of that population disaggregated by several demographic factors here, including race, ethnicity, language, housing status, gender, and then we have the overall at the very bottom to really help you understand where there may be disparities in those outcomes for these different population cohorts. And again, you'll see in those values are reflected in red are those values that are the lowest within that subcategory, and the values in green are the values, I'm sorry, yes, you're right. The values in red are where they're the highest, and the values in green are the ones where they're lowest. And we understand that there's a lot more work to be done in most of these populations, but especially calling out our white, non-Hispanic, Black non-Hispanic, and Native American populations where there could be room for improvement, as well as our English-speaking population, our unhoused population. And it looks like, from the sex at birth perspective, we can do probably a little more outreach for our males in the population.
Oh, yeah.
Yes. Any questions?
Just to compliment, I think the work on the diabetes breakdown, percentage, denominator, like total number, and then this breakout by race, ethnicity, age, housing, gender, really outstanding.
Thank you.
Thank you.
And just a real quick question for Dr. Lee, like, what's the benchmark here? Like, I know obviously 38% is not like, do you have a goal yet about what that, or the benchmark for that would be?
You know, probably best in class, if you can get this under 15%, you know, sort of where you see some of the Asian populations achieving some of the time. Now that's best in class, right? Folks are truly managed by a multidisciplinary team, engaged in care, without breaks in care. So we have a lot of room to go. So numbers in the 30% for A1C over 9 is pretty high, right? Joe, I don't know what folks achieve in your practice, but you know, certainly 30 plus
In
percent.
private practice, yeah, it's easy. It's this population.
Yeah.
It's a different dance altogether.
That's right. That's right.
To that point, Dr. Martin, when we have looked at the benchmarks, we do see that if we look at the HRSA benchmarks, the UDS, these are UDS measures, we're performing above. Even with these rates, we're performing well above those benchmarks.
Oh, yeah, in residency, if you got someone's A1C into single digits, you were like doing a jig. I mean, seriously, right? I mean,
Yeah.
so.
But that's the point to the earlier conversations, right? Just because that's the unfortunate standard for poor and uninsured and vulnerable populations doesn't mean that should be our standard, right? So we want to try and approach the highest standard of care, and the highest standard of care would be to get this down to the teens, I think.
And Sarita's team does look at some other clinical metrics and in other presentations. We look at national comparison data, we look at statewide data, and kind of how we're doing compared to those. So in other settings, a little more detail available.
Yeah, and as Alan knows, and Dr. Lee knows it, and Dr. President, if you get this under control, you don't need pediatric services, you don't need cardiovascular services, you don't need other services, because everything is controlled, and they just continue down their merry road. But if those metrics are not really tightly controlled, that's where the expenses, you know, go.
So are you saying does age play a part of this?
I mean, yes.
I mean, age percentage to race. If you have an older, an older black female population, would that make a difference compared to the other population? I'm just inquiring.
We can assume that's the case. We haven't done the deep dive to do that covariate analysis, but we can certainly look at that.
That's a great question. I think part of the physiology is coming into play then. I think, insulin sensitivity as individuals get older, depending on what happens to body habitus, it also affects insulin sensitivity. So I think we have to look at that. I do think, we talked earlier about transportation or couriering meds, to individuals who are housed or potentially mail order. I think some of the challenges that we have with, our populations or the communities we serve is they're not going to leave work to get their meds. If insulin is expensive, they're not going to fund the insulin. And so as we start to gap some of the affordability opportunities and we start to be able to deliver meds to houses or to area, cohabitation, anywhere where folks are residing, I think we're going to bridge some of these. We haven't been able to do so today because of those same challenges that, we haven't been able to affect.
The part of that, I mean, ethnically, socioculturally, African Americans, hypertension is devastating. Diabetics tend to be much worse in Hispanic populations and kind of older white people. And so it does change with age, but there's so many variables in that issue that I think if we kind of hit the metrics for everyone across the board, blood pressure control, cholesterol down, A1C, we really start to save serious money and get really great results for our patients that way.
In our presentation, we really just tried to hit the highlights, but when we talk about coverages and benefits, there are several initiatives that are in planning stages, but intended to help address exactly what is being discussed, where the medication gap coverage program that Dr. Schultz spoke to very quickly in the presentation is intended for when our patients age out of our program and into Medicare. Often our patients can't afford the Part D Medicare coverage that they need to continue receiving the medications they've been receiving the entire time they've been in the MAP program. Or if they move into the Medicaid program and traditional Medicaid, there may be a limit on the number of medications that you can get in a month from traditional Medicaid. So we're trying to plug some of those gaps as well as some of the financial ones to bring back proposals to you all if we can impose an out-of-pocket maximum related to prescription copays, so that if you're on 10 different medications, you can actually afford to pick up 10 medications. Those types of scenarios are things that our teams are working on.
I know we're on time, but because Manager Valdez said no questions, but then went ahead and spoke, I'm going to take permission to add one thought. It's really such an important point, Shannon, because and let's say, less disadvantaged populations that have good income, good coverage, housing, access, and so on, age becomes the main driver of frailty, multimorbidity, the place where you expect many things are then going to interact and perhaps accelerate their impact on a patient. But in our population, that happens younger. And we have, the reason someone's A1C is going to be high because they don't have access or they don't feel safe getting care, or they can't get from the bus stop to the access point because they would need assistance to do so and can't do so, right? And so there are many other causes of multimorbidity and frailty that intersect at our patients, and the intervention that may be needed is maybe food, right? It may be transportation. And so for us, having to dig underneath, that's why it's harder to get down to those teens, because there's so many more things that can drive truly out of control diabetes that are not medical in nature per se, but they're, of course, very relevant to someone's health.
I just want to make one comment about the foundations for those that can't afford their meds, and they're applying for the various foundations. The foundations are not going to automatically send you the refills. You have to call it in, and for a refill, if you're getting it every 3 months, you're responsible for that. And as you get older and you get more harried in your responsibilities, that's going to drop by the wayside, and so you're going to see a lot of people dropping dead or becoming out of control because they don't have. No one is regularly sending them their meds. I don't care if it's paid for by a foundation or not. No one's getting them. So if we're going to plan on doing something like that internally, then let's make sure it's automatic and not count on the patient to call you.
Okay. Okay, it's 4:30, everybody, just reminding you all.
There are 2 more slides and they're in the.
Yeah, but then there's a whole nother Board of Manager meeting.
So do we want to continue or do you want to review them on your own and come back with questions? So next slide, let's go to the next slide.
Save the best for last.
So this is your hypertension pressure control during a patient visit. So it represents a percentage of patients 18 to 85 with essential hypertension whose blood pressure was adequately controlled during their most recent visit, with the systolic being below 140 and a diastolic being below 90. And you'll see that we've this one, the higher the better. This one, the higher the better. So you'll see that there was improvement over time and up to Q1 of this year. So we'll have to investigate to understand why those decreases happen. And we don't see necessarily the same seasonality in these data as we look at them as the A1C, which is why I suspect that it has a little bit to do with that timing. Let's go to the next slide. And this is the breakdown of that information. Understanding again, room for improvement, among all groups, but some groups, the ones that are in green, faring better than others. Any questions on this?
commenting clinically for a moment. You do see some good trends to improvement over time. And maybe if over 80% might be sort of gold standard best practice here. There are some populations approaching that. And the other thing here is hypertension is often mitigated by measurement issues. If you don't take the blood pressure correctly, 5 to 10% of hypertension is actually just we didn't measure it properly. And you just run in from the car and we take it with your feet dangling over your sweater, right? It's, you're not hypertensive. So these are actually pretty good numbers, all things considered, and there's still room for improvement.
Okay. Managers, we do not currently have a scheduled Central Health Strategic Planning Committee meeting. Yeah. Cynthia, okay. We do not currently have a scheduled Central Health Strategic Planning Committee meeting in the future. So when a need for a meeting arises, we will work with committee members and other managers to choose a date and time that works with everyone's schedule. And at this time, I am ready to accept a motion for adjournment. Cynthia, and second, Joe? Okay, Dr. Martin. All in agreement? All right.
Okay, good afternoon. Today is June 11th, and it is 4:34. As the quorum of the board is in attendance, I'd like to call to order the meeting of the Central Health Board of Managers. I don't think we have anybody on by video conference, so we'll proceed to the regular agenda. Managers, we just have one item today, and the reason for us doing this meeting today is because we have a deadline. We have a deadline to meet to get this recommendation to the Commissioners Court, and they have a deadline that they have to adopt by. So that's why we're doing this today. So the item is discuss and take appropriate action on a recommendation of the Central Health Tax Year 2025 Homestead Property Tax Exemption Rate and Homestead Exemption amounts for Travis County residents who are over 65 or disabled. Basically, we've got two things: our homestead exemption percentage that we set it at, and then we've got the numerical value of our exemption for disabled and for people who are 65 or older. And we'll make a recommendation on those. We'll vote and make a recommendations to the Commissioners Court on those. So we have a presentation. It's 4:35. I think that this should go fairly quickly. And then it just depends on how much questions you guys might have. So please go ahead. Mm-hmm.
Good afternoon, managers and Chair Kitchen. Thank you for laying that out, Chair Kitchen. Thank you so much for taking the time for this special called board meeting. We do have a deadline, ultimate deadline of June 30th to get this to the Central Appraisal District. But before that, we do need to recommend these local exemptions to Commissioners Court, which is on their agenda, I believe, June 24th. So there are local exemptions that we have control over. One is the homestead exemption. As long as I've been in Travis County, and here it's been at 20%. The city didn't always have that, but Travis County did, but they also have 20% homestead exemption now. 65 years and older and the disabled are a fixed dollar amount, as Chair Kitchen mentioned. We usually try to increase those each year so that they're held harmless on any tax increase that they see. So on the homestead exemption, as I said, the max is 20%. We're at 20%. We recommend staying at 20% for the homestead exemption. For the 65 and over, when I put this together, the city of Austin and Travis County had proposed these amounts: $192,000 for City of Austin and $143,220 for Travis County. Those are both increases. They have now voted on those, and those are now approved. Okay. For Central Health, right now, our exemption is $154,000. We recommend to hold those 65 years and over and disabled, to hold them harmless on any increase in taxes at 6.5%. That would be, increase it by 31,200, which is a 20% increase, to 185,200. And by doing that, it does, whenever you put an exemption on one part of a group of taxpayers, it forces other taxpayers to absorb that. And so other homesteads, just the homesteads, are absorbing it by 89 cents per $100,000 of value, which I think is like $5 for the year. And so therefore, that's what our recommendation is for that. Is there any discussion or any questions about that?
Let me see, let me go around the room. We'll start with Manager May. Do you have any questions?
No questions.
Manager Jones, any questions?
I want to make sure there's no conflict of interest in voting on this, given that I'm in one of those categories.
No. You're not, the board's not gonna be able to pass if we do that, so we're not gonna be able to vote. But anyway, or just a few of you can vote.
Can you
Anyway.
tell us the percentage amount instead of the dollar amount? Like, are we raising our percentage?
We're raising it 20%.
And so so we were at like what percentage last year and what percentage?
So it's not a percentage, it's a dollar amount.
It's a dollar amount.
And so it was at 154,000, and we're raising it 20%, which is 31,200 to 185,200. Does that
And-
answer?
Yeah. Okay, did you get your question? You have a question? Have a question?
The only one I wanted to know is whether or not
Wait, y'all, go ahead.
AISD, if we had that number for AISD, they're normally the highest tax rate.
I don't have their taxing totals. I would need that to be able to figure out. Okay, so they have a different, their exemption amounts are different. I do know that Perla sent me an email about some bills that are with the governor right now for the exemptions for ISDs. There's several bills.
Yeah,
Okay.
that's okay, go ahead.
Okay, go ahead.
Yeah, the compression of taxes is different with the
Yeah, taxes are different. Yeah.
Just a real quick question. So in order to hold them harmless, you're anticipating that the Central Health Board recommends a 6.5% tax rate increase, is that?
That's what has been the forecast on our health equity plan,
Yeah.
our strategic plan, and so we stuck with that percentage.
Yeah, and so that's the rationale for the increase in the homestead exemption.
Yes, I have to consider the tax increase if I want to try to get to a dollar amount.
And just one other quick question, the disabled homestead, I'm not sure, I was listening why the exemption didn't move up.
It does. It moves up for both of those.
both, the same
For
amount.
65 and over and disabled.
Oh, I'm sorry, I was just reading the slide that says keep exemption at 154, is that the other option?
That's just that is an option that you have
Oh, I
if
see.
you didn't want
Sorry,
to increase it.
I was just,
Yeah, that's
I
okay.
was reading it literally versus as an option, where you're just showing that if we don't do it, those over 65 disabled will have a $36.
Correct.
Okay, sorry.
Yes.
I
No, that's
didn't
okay.
understand that. All right, thank you.
Okay. Okay, so yes, I think this is a good recommendation. The practice of holding folks harmless from the previous year to the next year is a good practice, and that comes into play because of, I'm not gonna try to explain it. You could explain it better. But anyway, it comes into play. If we don't hold them harmless, they're actually going backwards, and so that's the reason for figuring out raising it to 185. So I support y'all's recommendation. Do you have a question?
Are you entertaining a motion?
Yeah, I am.
Okay, I move.
Okay.
I move that the board request the Travis County Commissioners Court approve our Central Health 2025 tax rate homestead property tax exemption for Travis County residents at the maximum rate of 20%. And that the Travis County Commissioners Court also approve that the Central Health 2025 homestead property tax exemption for Travis County, 65 and older or disabled, be held to the amount of $185,200.
Do I have a second?
Second.
Second, all in favor?
Aye.
Okay, it's unanimous. Thank you.
Thank you.
Okay, so, let's see. Our last item is to confirm the next regular board meeting date, time, and location. Our next Central Health Board of Managers meeting is scheduled for Wednesday, June 25th at 4 p.m. at these headquarters. I want to make an announcement before I take a motion to adjourn. Tomorrow is our presentation to the Travis County Commissioners. You all may remember that Central Health presents to the Travis County Commissioners on a quarterly, periodic basis. So that's tomorrow. Travis County, Central Health is tentatively scheduled for about 2:30. So you are all welcome to attend or to watch if you would like. Brianna's going to share the slide deck by email so you can see that. The other thing you might be interested in is that Integral Care will be making their presentation right before Central Health, so they are scheduled for 1:30. So just wanted to let y'all know about that if anyone wants to watch or attend. So at this time, I'm ready to accept a motion for adjournment. Manager May, second, Manager Valadez, all in favor? All right, thank you all very much.